Can you hear me now, Shane?
Barely.
Barely?
If I listen hard, I can hear you.
Okay, Mr. Chairman, we're streaming live on YouTube. Can you do a sound check, please?
We've got an echo in this room.
Please stand by for just a moment while we work on audio video difficulties.
Turn the volume down on your computer, would you please? Turn the volume clear down to 0. I need to turn your volume down because if I go with mine, it echoes. Here.
Get my notes here. We're going to do another sound check. Go ahead.
All right, can you hear us okay now?
Yes.
Yes.
Okay. Can you get a little more volume?
Yep, we're good.
All right, sorry for the technical difficulties this morning. Such is the case with trying to do meetings in a little different way than we're used to. But I think we've got everything going now. Director Rakow, can I go ahead and begin?
Yes, Chairman, go ahead, please.
All right. Well, welcome everybody. This is the October 8th meeting of the Eastern Idaho Board of Health. We have several formats going here. We do have our meeting streaming on our YouTube channel for the public to be able to log in and see live or listen to it later. We hope this has been a convenient way to keep these meetings open to the public. We also have a room set up at the Eastern Idaho Board of Health building for any public that may show up at that location. They will have access to the meeting. I will go ahead and do a roll call of the counties just to make sure that I do not miss anybody. We'll go ahead and start with Jefferson County.
Shane Young here.
Okay, and Madison County,
Brent Mendenhall, present.
Fremont County,
Lee Miller, present.
Teton County,
Bill Lake, present.
Clark County,
Greg Shenton, present.
and let's see, Custer County.
Wayne Butts, present.
Thank you, Commissioner. And Lemhi County,
Ken Minor, present.
our physician, Dr. Nelson.
Barbara Nelson, present.
And did I miss anybody?
Yourself.
Of course, I represent Bonneville County, Brian Reed. Thank you to all of you board members for making time this morning, and particularly thanks to the staff of Eastern Idaho Public Health for all the work that they put in to be able to hold these increased meeting cycles, and along with all the work that they're doing to help the community at this time. We will go ahead and begin with a approval of our October 1st Board of Health minutes. You can see those on the screen. They were also sent out and they are on our website. If no changes are needed, I would entertain a motion to approve.
I move we approve the October 1st meeting minutes.
Thank you, Dr. Nelson. Is there a second?
This is
Shane
Bill
Young,
Lake, I
second.
Okay, thank you. We had a second from Commissioner Young and Commissioner Minor. All in favor, say aye.
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 Is there anyone opposed? All right, thank you. Well, we will move on to the next item on our agenda, which is Eastern Idaho Public Health Division updates. It has been a while since we've been able to see or hear from our division directors. And we know that they have been continuing on with the extensive work that they do during this time that we've been so focused on the pandemic. But we do appreciate the continual work that they do, the importance of the work that they're doing, and look forward to a report from them this morning. So we will begin with Kelly Johnson from our environmental health. Kelly, can you hear us? Or you?
I can. Can you hear me?
We can.
Okay. So I appreciate the opportunity to just give you some updates. So back in February, you helped to allow me to create a new position in the environmental division. And due to COVID hitting in March, we put that hiring on a freeze, basically. Things have been very busy in our septic program and land development. So we have moved forward with the hire on that position. And starting on November 2nd, we have Christopher Ellis coming to work for us. He actually is already an environmental health specialist at a different health department in the state, and will be moving to Idaho Falls with his family to join us here. So we're excited about that because he will basically come to us with all the training that's needed to be able to just jump right into our programs. So that's going to help us a lot. And we also just had a staff member join us from a vacancy in Teton County. So Kathleen Price joined us this Monday, and she is already out doing the field work that's needed to help our on-site program and our land development program. So we are fully staffed starting the beginning of November. We haven't been that way for a very long time. So we're excited to have all the expertise that we have with our staff in the programs that support Eastern Idaho. Also, coming up next week, we'll be having an audit by the State Department of Environmental Quality, but it will be a virtual audit where Peter Adams will be reviewing our on-site program work through our Paragon with a live link to the database as an auditor function. So we'll keep you apprised as to how that audit goes. And then finally, just with day-to-day work, we've been busy in our food programs, activities, of course, just trying to catch up with everything from COVID that may have been put on hold with businesses not being open. But we did have a situation where I had gone out with a staff member to do an investigation after a compliance issue. And when we showed up on site, we found that the item had been corrected, but there was a new owner to the business. So I did have to shut the business down until we got all of the right licensing taken care of for that business. And then a week later, we found, unfortunately, that the same owners had bought a different business, and we had to turn around and do the same thing with shutting them down because they were operating illegally as a food establishment. And staff and I did work with them to get their business back open the following week. So we just wanted to let you know that, you know, although we don't like having to do enforcement, we do our job to make sure that facilities are operating according to the rules. And we do that, you know, carefully and timely to make sure that when we do have to close them down, they know what they need to do to open back up again. So it was a kind of a short-lived business being not able to operate, but when they did operate, they opened up meeting all the rules and the requirements. So that was a positive outcome for 2 different food establishments. And then just last week, I was out doing a investigation at a childcare facility and did find some pretty major violations going on at the facility. So with the help of the Department of Health and Welfare, who's actually responsible for licensing, we have shut that facility down and working with them to get all the violations corrected to where they will hopefully be able to operate again in the coming weeks to be able to support the families that, you know, take their children there to be watched. The priority there is that they are being watched safely and meeting all the rules for those children to be kept safe. So that's all I have to share as far as environmental. If there's any questions, I'd be happy to answer them.
Any questions from the board for Ms. Johnson? Well, thank you. We appreciate that report. It's good to hear from you and the work that you're doing.
Thank you.
We'll move on in our agenda to our clinical services. So that's Amy Gamet.
Good morning.
Thanks for joining us. Good morning.
I'll just share my screen. Can you guys see that? And Jerry, can you see the screen?
Yes, we can see it.
Alrighty, thanks. I just wanted to do 2 updates. One would be on influenza. Since the first week of October, August starts our new influenza season. And then on hepatitis C that we had talked about. Seems like a lifetime ago, but just back in November. A little recap of last year's influenza season. Activity had begun in November and was highest January and February, and then did have a pretty sharp decline in March. Some speculation, you know, that decline was due to COVID and all the mitigation factors that were in place for that. The season was characterized by 2 waves. We've seen a lot of influenza B early on here, and then followed up by influenza A, which is still the H1N1 from the pandemic of 2009. Overall, that H1N1, those viruses were what we've seen most last year, and it still continues to be in the influenza vaccine. The season was described as being moderate last year, just a unique hospitalization rates for children 0 to 4 and young adults, so 18 to 49, were higher than it normally had been for the past several years. These are preliminary numbers, but CDC is estimating last flu season, 38 million cases, 18 million medical visits, a little over 400,000 hospitalizations, and 22,000 deaths. I did pull Idaho's, and still, again, preliminary. It looks like Idaho, though, has reported last year 39 influenza deaths, and 2 of those did include pediatric. So this year, it's going to be particularly important for everybody to have their influenza vaccine, and mostly because just the strain on our healthcare system. We already know influenza season puts a strain on the healthcare system each year. And so in light of COVID, we want to try and reduce that the best we can. And so here at the health department, we wanted to think out of the box to be able to provide access safely and easily. And so we decided to implement some drive-through influenza clinics. Just want to give you an update on those. We did a trial run with our staff here at the health department. We sent out a survey monkey asking for a lot of feedback. Most of the feedback came in signage and to eliminate some sharp corners for our drivers. So we had some lessons learned from that clinic as well. Vehicles come in all shapes and sizes. Somebody came through with a trailer attached. We thought we'd be able to just hang arms outdoors, but that always didn't work. Many times we had to open a car door to access somebody. And that paperwork definitely took the longest when people were in line for shots. So today we ran our first public clinic. And so here's some pictures of that. You can see we had mostly cars. We did have some on bikes though, and we also had one pedestrian show up to our drive-through clinic, and we accommodated everybody. This is actually Dr. Nelson's daughter that came through, so gracious to let us take pictures of her. So just handing her paperwork back, and then her actually receiving her influenza vaccine through the window. People were happy, thrilled. These are our happy customers here after their influenza vaccine. So the first one felt successful, and people were very appreciative of the flow. We had several large families come through. They said they appreciated not having to drag their kids in, or they were able to fill paperwork out while they're still seat belted in, and then pull up and have everybody vaccinated. We definitely had the capacity to vaccinate a lot more. We did 100, and I think we probably could have done 300 there. We're also providing those same type of flow clinics to large employers. We have some big employ a lot of people, and they're doing the same thing for their employees and their families. Just like us, we understand the importance of not just vaccinating the employee, but also making sure all their family members are vaccinated as well. I would suspect just after having one clinic that this is something we would continue even after COVID. Every October probably have some drive-through influenza clinics. So any questions on that before I start on hepatitis C?
Any questions from anybody? I know I've had the question come up if with the influenza vaccine, is there a optimum time to get it? Can you get it too early and then lose effectiveness later, or how does that work?
We hear that all the time. Ideally, you want to have it by the end of October. Our flu seasons tend to start in November, so you want to be protected. And then you're right, you wouldn't want to be vaccinated in July. So ideally, October is the ideal prime time. And then when we're into that February, March, April, flu season, you would still have coverage for that. Good
Thank
question.
you.
I get asked it all the time.
Yeah.
I was sad that everybody wasn't down here for me to be able to give them their influenza vaccine today. So definitely reach out to your local public health there or your provider to get those. All right, I'll move on to hepatitis C treatment. Again, in November, I presented on hepatitis C and being able to implement some treatment for that. Just to recap, hep C is a liver disease. When somebody initially becomes infected, they can have mild symptoms or have severe enough symptoms that they're required to be hospitalized. The downside either way, most people that get infected develop a chronic lifelong infection. We know it's the hepatitis number one cause of liver cancer, but also leads to liver failure, transplants, even death. Total healthcare costs for hepatitis C infection right now is about $6.5 billion annual in the US. In 2024, they're estimating that to be up closer to $9 billion. So very expensive to treat. Anytime you're treating somebody for a lifelong illness, that's what those costs become expensive. Just a reminder of how it's spread. Before 1992, our blood wasn't screened for hepatitis C. So if you received a blood transfusion before 1992, recommendations are that you be tested for hepatitis C. It's very contagious, so sharing any personal items, razors, toothbrushes, unregulated tattoos or body piercings. We see healthcare exposures, and then shared injecting equipment. The last couple of years, though, we now know that there's a short 12-week treatment. With that treatment, 95% of people with chronic hepatitis C are actually cured. As I spoke before, though, it can be expensive and difficult to navigate. So what we did here is we developed a policy. We contracted with a local lab to provide some affordable lab testing for those clients. And then we developed some processes to help with patient navigation for people that are uninsured or underinsured to have access to those medications. And then also developed a process of how to work with an insurance company to provide coverage for those treatments. So where are we today? We had our first patient, a female in her 60s. She did have insurance. We were able to help her navigate through that, where they were able to provide coverage for it. She'll be back in the first week of December. We'll do a viral load draw at that point, and we'll confirm, hopefully, that we were able to cure her of a chronic disease. And our staff are excited, especially our clinicians, our nurses, to be part of something that's going to cure somebody, from 40, 50, 60 years of a disease. So very excited, amazing. And hopefully I'm back in December telling you that we did that as well. I think that's all I have right now. We're just very busy starting with the influenza season. So any questions on hepatitis C for me?
Any questions from any of the board? Thank you very much. Appreciate that report. We'll next go to our nutrition division with our division director, Angie Harwood. Good morning.
Good morning, thank you. Just a quick update with the WIC program. For over the past 6 months, we've been providing remote WIC services. And what that means is we're able to serve participants over the phone. So they send us their documentation digitally, and we're able to determine eligibility, do a questionnaire and assessment, and we're able to provide education and load benefits remotely. This was made possible because the USDA gave us a waiver to waive physical presence, which was a requirement for WIC previously, and also allowed us to issue benefits remotely. We learned at the end of last month that the waiver was extended, and it will continue through 30 days past the declaration of a national public health emergency. So we know we'll continue to do this for a while. We have staff stationed providing remote WIC for the entire district. We have staff stationed in Rexburg, Rigby, and Idaho Falls offices. And then we have someone in Salmon also. It seems to be working for us. We've had to be pretty resourceful, and staff have done a great job with that. We're providing breastfeeding support and breastfeeding classes via Zoom. That's our peer counselors are doing that. And we've uploaded all of our education materials onto our district website. So if it's something that a participant would normally walk out of the office with, a piece of education material, they can look it up on the website, and we're directing them to that. And then fortunately, over the past couple of years, we had converted to an EBT card. So participants were receiving their food benefits on a card versus the paper vouchers. So the cards are easier to load the benefits up remotely. And then we had also implemented a WIC Smart, which is online nutrition education that participants can access from their desktop or their handheld device. And so we have education options other than just talking to them over the phone. So it seems to be working. Our numbers are holding. Yesterday, I looked at our participation numbers compared to this time last year, and we're up about 250. So overall, as a district, we hover just under 6,000 for participation. Any questions on the WIC program?
Question from anybody? Thank you very much.
Mr. Chairman, I'd just like to say a big thank you to all the division directors at this time. I know it's been a difficult year, and it just goes to show you what a great staff Jerry's put together to operate in these difficult times.
Thank you, Commissioner. I think we all second that. It has certainly been an unprecedented year, and the work that's come out of Public Health has been phenomenal, including all of the divisions that have been working behind the scenes in what they've been doing. So thank you to all of you. I echo that. So we'll go ahead and move on then in our agenda to our fiscal year 2021 financial report. Our Chief Financial Officer, Stephen Thomas. Let's see, are you with us? Can you hear us all right, Stephen? We're not hearing you. I don't see him on, is he? Go ahead and pause just a minute here and we will get him connected.
Both have to okay, it's a trick. There were two buttons to unmute, and I only found one. Can you hear me now?
We can hear you now. Thank you for joining us this morning.
Okay. Apparently I was double muted. All right. Kind of as a big overview, COVID is also a financial event. As part of this process, we need to expand our budget so we can continue to fund all the new employees that we've acquired. But overall, our expenditures are very close to budget as we're still in the first 3 months, and the expansion in our expenditures has not been so extreme to overrun our budget line in the first 3 months. If you kind of look at the expense summary, just go down a page on the screen. That's the cash right here on the expense summary. Over in the percent used, I'm sure the board feels like they're 47% when we're only 25% of the budget, in that we've had a lot of board meetings and activity. Most of the rest of the divisions are close to their current budget structure. Anybody have any questions on that? You'll notice down at the bottom, we actually did get a vehicle come in September that was ordered in January. COVID shut the factory down for a few months, and it finally came in September, one of the 3 we ordered.
Any questions
There's
from
no
the board so far? So I guess I'm just curious of the additional expense and where it's fitting in our budget for the additional staff that you've had to hire for COVID.
The additional expense is actually up in emergency response. And there is no percentage because there was no original budget for that. When we built our original budget, COVID didn't exist. And so we have about a $250,000 cost so far, but the number of contact tracers coding into our contact tracer program went from around 10 in July to almost 20 in August to over 30 in September. So that the operation of contact tracing has dramatically expanded in 3 months. And if you look at our new case numbers, it kind of gives you a clue as to why that's happening.
So has there been any challenge in hiring that many additional contact tracers? James, would you speak to that?
Yeah, so this is James, and certainly as training occurs with those contact tracers, they become more proficient. With the specifically to the question about getting individuals, there's always hurdles to cross when hiring individuals, you know, getting good qualified candidates in to where they can come in and have the appropriate timing and some of those things. I will say that we've been able to manage and to get good quality candidates, and they've helped us be one of the better contact tracing units across the state, I would say. We've been able to keep up with cases and to do contacts, and I can say that I have a great deal of admiration and also just trust in our contact tracers that we've been able to hire. We're continuing looking to get those so that I don't burn them out as well. So.
All right, thank you. Is there any other questions for board members so far?
Yeah, this is Bill Lake. I have a question.
Go ahead, Bill.
I was under the understanding that we didn't get any additional funds to deal with the COVID-19, but I understand from our emergency manager here in Teton County that the state has issued $6.9 million to the public health districts, and I just want to get clarification on, have we gotten additional funding, and how's that, what are the strings attached to that?
So Bill, this is Jerry, and I'll start and then Steve can continue on because that's the next portion of our agenda that we need to talk about budget adjustments, and they're all directly related to COVID-19. So early on, when the state received the CARES Act funding, the public health districts did submit application to receive funding for contact tracing efforts. A total of $6.9 million was set aside for that. And you can see on the screen that is on the spreadsheet that's on your screen now, that's the second line item, CARES Act. Our health district was, appropriated $466,000 for that, but it's a reimbursement process. We have to spend the money upfront and then we could submit for reimbursement for that. And it can only be used for contact tracing. And it ends December 31st.
Okay, thank you very much.
Steve, do you want to add anything or just go into this next question?
I was just going to add on CARES Act, partway through September, we got new guidance, which is still being discussed with the governor's office, the fiscal officers, and the directors, where they're looking to expand some of the things we can do with that funding. The $466,000 is our current estimate of what we'll spend through December 30th, because those funds have kind of like a short window of time where we can use them. And that's why on this one, we're asking for a budget increase, because we're expecting or currently budgeting to spend $466,000 between July 1 and December 30th out of the CARES Act funding. I can talk about the rest of these. The one other thing I was going to highlight from our revenue page before we go into the budget change, if you go up here on the contract revenue, and then you go down into fees, not sure exactly where else to put it because I haven't had significant donations before, but where we see community health fees total, in August, we did get the DOE payment of $194,000. That was discussed, I believe, in a couple of different board meetings. I just wanted to make the board aware that those funds finally actually came through.
Hey, that's good. Good to hear.
Okay, that's kind of like the one revenue thing I wanted to highlight. Then we can move back to the budget adjustment. The CARES Act funds came as a lump to the state of Idaho. They created the Corona Financial Advisory Committee, which is chaired by, I believe, Alex Adams, who is part of the governor's office. And we submit very detailed requests. A billing can take upwards of 10 or 12 hours to prepare because we have to give them an explanation of what everybody's doing. Each operating expense has to include copies of invoices, just a very detailed billing, and then they go through a process of approval before they finally reimburse us. These other items, the COVID crisis subgrant, the COVID school support subgrant, and the EPI expansion subgrant are subgrants that have come to us through health and welfare. The COVID crisis subgrant came early in the process, and we have already expended a fair amount of that grant. This $195,000 is what is left during this fiscal year. The school support subgrant is brand new, within the last week or two, I believe. And we're still developing, I believe, plans with that. James could maybe talk more to it, but it's still very new. The EPI expansion subgrant is a longer term funding to kind of carry the contact tracing and emergency response past December 30th. And that's a fairly large grant. However, depending on how the contact tracing continues, that may or may not even be enough funding long term. Because the contact tracing seems to be using close to 100,000 plus a month at this point, with possible expansion happening. Any questions on those four funding sources?
Any questions from the board?
I would just like to ask James to speak to general activities within each of those subgrants.
Yeah.
There are specific deliverables that we're required to perform with those. It's just not open use for whatever.
Yeah. So, and Steve mentioned the COVID crisis subgrant really was early on. It was an initial funding for to do some preparation work, and that money is continuing. The CARES Act we've talked about, it's dedicated solely for contact tracing. Each of those individuals is helping to, or that money is really helping to provide contact tracing support. So those individuals that we've gone from 1 to 2 individuals up to 20 now, gaining into 30 as we expand that capability and out of case counts. That money is dedicated to that. The school support subgrant, really, we did actually just receive this last Friday. We're still working through some of that scope of work. A big portion of that you can see is operating. It's to try to help facilitate testing of teachers, students, and well, I should say teachers and staff and possibly students. The state is still helping to provide and to get guidance for us exactly how they want us to implement some of that. We will work to continue to refine that with them so that we can help schools really with the governor's desire of having students in schools, as well as our desire to have students in schools. It's the wage that is there to have a points of contact here at the health department to do for those schools to get the necessary information and on a rapid basis. I'll say that right now that's just being handled by Jerry or myself or an epidemiologist. So having extra staff to help bear that burden is there's multiple schools within the district. The EPI expansion subgrant, Steve mentioned this. This is due to run longer than just where some of these others are really just to the end of December or to the end of the school year. The EPI expansion subgrant is into 2021, so that we can continue the efforts for both COVID, but other infectious diseases potentially as well, to have enough staff to and then build up the capacity in other areas of our communities with infectious disease principles. So that's a small snippet on each one, but really EPI expansion subgrant deals with infectious diseases and expanding those services and building up that capacity, potentially even after COVID winds down. The COVID school support is really to help start facilitating testing and to have points of contact with the schools and to develop their ability to respond and to keep kids in school. The CARES Act, again, is for just the increase in contact tracing as we deal with a large number of cases. And then the COVID crisis subgrant really was an initial funding to help as we mounted the response to COVID-19.
Okay, thank you. So Steve, what are you asking for today then? Am I understanding this right? A total budget expansion of 1.863,495, is that?
Correct. And this is our current best estimate. This has been a really moving target. So hopefully we don't actually have to spend all that much before the end of this fiscal year, but it's possible based on the contact tracing expansion. Because once we hit January, that EPI expansion subgrant will have to take over funding our contact tracing operations.
Okay. And that is a significant number, but I appreciate what you said. We will continue to operate on the fiscally responsible way that we always do at East Idaho Public Health, and it may not all need to be spent, but it looks like between the grants and the CARES Act that at least you have those resources to come in to be able to appropriate. Are there any questions from board members? If not, I'll need a motion to approve a change in the budget then to expand it with an additional $1,863,495.20.
Mr. Lake, I make a motion to approve the budget expansion as presented by East Idaho Public Health staff.
Wayne Butts would second.
Okay, there's a motion and a second. Is there any discussion on the motion? Hearing none, all in favor say aye.
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 Are there any opposed? Did anybody abstain? All right, thank you. And thank you, Stephen, for your continued work.
You are welcome.
We'll go ahead and move on then in our agenda to the review of public comment. Excuse me. I'll kind of summarize a little like I do. We did receive several comments. A lot of comments came in yesterday, and the last one I had was a very well written and sincere letter at, I believe, about 1:30 this morning. And so we do appreciate everybody for taking the time to comment. We read each and every one of them. I know in my case, and I'm sure the other board members, we review it in our mind, we consider it, and we do appreciate the input, and it does help in our decision making and the thought process we go through for each and every meeting. Many of the comments were answered directly this week by either staff or board members. And I appreciate the time that it takes to do those and those responses that were made back. There were a few letters, emails that were received that were opposed to any mandates whatsoever. They believe that our board should not take any action whatsoever, and that it should be left up to the individuals in response to the pandemic. There were several letters received that did support our work. They encouraged us to not get discouraged and to keep doing what we can. I appreciate those letters because I think a lot of them came because there were comments from us, including myself, that it is discouraging to all the work that's been done, and then the case numbers continue to rise, and the hospitals reporting increased admissions. And so appreciate those letters. There were several emails concerning the current situation in Madison County, and understandably, some of them expressed curiosity of why we didn't address Madison County more thoroughly last week, since they had been above the 50 per 10,000. That, although it wasn't an oversight, it was probably an oversight in my place to not mention that our staff was working really hard on that. We were all working and trying to formulate in our mind to make sure that any decision that we made would be the correct one in regards to our plan. So we did mention the need to probably revisit the plan. We didn't tie it directly to that. And so for that, I apologize, but I can assure you that it was foremost in our mind because of the rising case count in Madison County. And it will be discussed more thoroughly today. Several pointed to the New York Times article that places Rexburg now as the #1 hotspot in the nation. That is unfortunate and somewhat surprising in my mind, and I hope that we get some understanding today of why that might be happening, and ways that can be slowed down and reversed, and we can get those numbers and those cases back down, particularly up in Madison County and throughout our district. There were questions from up there of who they can contact to get more proactive measures taken. I would just say and I know the elected officials up in Madison County and Rexburg are working hard on it now, and they hear your concerns, and they would be a good one to contact, as well as school board members, and they too, I know, are working hard on it, as we all are. There was one comment that said that a rule without a consequence is merely a suggestion. And we understand that. And we hope that everyone will follow the guidelines that have been put out. I also there was a couple of emails that came in that referenced the Great Barrington Declaration that came out this past weekend from a group of highly respected epidemiologists, I believe it was, from Massachusetts and Oxford. Their credentials were impressive. It was co-signed by some great people, talented medical professionals and epidemiologists and all across the board. And I read through all of us. I'm sure all of you did. I listened thoroughly to the video, and it was very compelling in my mind. I felt like it had great merit, and I'd like our board to have a bit of a discussion on it this morning. I wanted to point out some things that first struck me. And from their declaration, one of the paragraphs said, current lockdown policies are producing devastating effects on short and long-term public health. And they went on to say that stopping screening cancer screenings and all other medical needs that stopped during the shutdown were harmful. Keeping students out of school is harmful and a grave injustice. When I read that, the first thing that came to my mind is, well, that's not what is happening here in our district. In fact, quite the opposite. Every mitigation strategy that we are trying to recommend and encourage is to keep all of those things open and going. And so it seemed like, I agreed with it, but it wasn't our situation here. They also went on into another paragraph and said extracurricular activities such as sports should be resumed. Well, they are continuing here. They've never, well, at least this fall, they resumed and haven't stopped. And again, everything that we're doing is to try to support that those things can continue to happen. And so I found myself agreeing really with the strategy, but I felt like the measures that we're taking and our board is trying to support those things actually, and help all of those things continue. So are there other comments from the board, Dr. Nelson?
Yeah, the Barrington Declaration strategy is one of focused protection. So it advocates for protecting the vulnerable and wide opening everyone else. And I'm going to use the flu season as an analogy to this. We do focused protection during the flu season. We vaccinate our high-risk populations. We vaccinate pregnant women. We vaccinate children to protect the elderly around them. But the difference between the COVID and the flu season is for influenza, we have treatment. We have a vaccine and we have treatments. We have antivirals that we can give to people when they come down with the flu. COVID is extremely different in the fact that we do not have any of those mitigation strategies. We don't have a vaccine. We don't have an antiviral that's approved for general use. So even though there's the concerns of all the health problems, our mitigation strategies are to try to keep us open, try to keep our schools in session, try to keep sports going. But I do not advocate for a wide opening because until we have those mitigation treatment, including a vaccine for COVID, opening wide open would be disastrous, as we're going to hear from our hospital specialists of how our hospital system are currently in a tenuous situation. So we could do focused protection when we have a vaccine and when we have antiviral treatment that we can use in wide use for people who contract COVID.
Okay, thank you. Are there other comments, questions from board members? Commissioner Mendenhall?
Yeah, yes, please. And Dr. Nelson, help me understand why those, we have addressed in the past to listen to those who are specifically in virus management and epidemiologists and from Oxford, Stanford, Harvard medical schools. why would they not take that into account? The things that you said, we don't have those tools available. Surely they have also registered that if they are the experts. And if you can
Epidemiologists
understand,
don't work in medicine. They don't work on the front lines of medicine. We need to listen to the people who are actually treating COVID patients. I know there's been other so-called experts that put forth their opinions, but when you look at the overall picture, you have to take into consideration so many other variables when you make sweeping decisions for communities.
Other questions? Commissioner Mendenhall?
no.
This is Commissioner Young, Mr. Chairman. May I make a comment?
Go ahead.
Yeah, I did read that and I did listen to the video. And just a few questions pop up in my mind, and maybe somebody can correct me. But right now, we're having difficulty getting everyone to buy into the guidelines the Eastern Idaho Public Health has put forth, especially on the mask mandate. I'm not sure how, without infringing on people's rights, how you force people who are in a high risk group to isolate. How do we do that? Just to take our example of me and my wife, I think they said, one of the areas they want to focus in is that people 60 and over can, I heard the word used, take sabbaticals. And where my wife works as a registered nurse at the dialysis clinic, and the other nurse on staff there is a registered nurse. They're both over 60. And so we, do they tell their dialysis patients, they wait 3-4 months so that, so we can get through this COVID. So in some ways, I think that lacks practicality. Now, with that being said, I do like the idea. How can we help? And maybe there's something we can do as a health board or things like that. Just one idea that come to my mind is maybe businesses can work with the community somehow to, when it first broke out, they worked with the community, providing times when the elderly and things like that can do their shopping and things in town. And maybe there's something that can be done there. I don't know, where mask mandates are better enforced at certain times, in the morning or however. I'm just wondering if there's something we can do to maybe help this, to give the vulnerable more chances to go to town, to do their business and be safer. That's all.
Okay, thank you. Other comments from board members?
Mr. Chairman,
Yeah, go ahead, Commissioner Miller.
I took quite a few notes while I was listening to that presentation, and I have to agree with the things that you've talked about, that it really does align with the things that we're trying to do. Some of the concerns I had is they made the comment that within 90 days that this could be controlled, but then they talk about the vulnerable, and I'm one of those in that age range, and I'd hate to be isolated for 90 days strictly. So, there's some good things about what they're saying, but I think we are trying to align with keeping businesses open, keeping activities going forward, and giving as much ease to the public as we possibly can.
Okay, thank you. And yeah, correct me if I'm wrong, Dr. Nelson, but the focused protection that it's called, that's why we wear our face coverings, right? That's why we social distance, is to protect particularly that segment of the population. I become hyper careful whenever I'm approaching anybody that I know may have that. And I keep even a greater distance. Even my own father, who's 89. I am extremely careful, especially if I've been out in the public at all and I'm worried at all, then I'm even more careful around him. And as hard as that is, that's what I do. So in a way, I do a focused protection, I think, on my own. But I think I do agree, and somewhat with Commissioner Mendenhall, that there there are good points that are in that we do need herd immunity. And I believe that herd immunity comes through the vaccine, right? I mean, that helps us get there. I agree with Dr. Nelson. There would be a lot of harm to even young people or others, that would come if everybody had to just experience this disease. Most likely, I think there would be.
Well, look at my example of the flu virus, the flu season. It's like a compliance issue. We wouldn't have as many hospitalizations and deaths if we had more people getting the vaccine. I think the statistic is something like 45% of adults get the flu vaccine. And the estimates for COVID is we have to be somewhere upwards of 70% of the population having immunity for herd immunity to kick in with COVID. And, I think the estimates are somewhere at 10% of the population has been exposed to COVID in the United States. So we are a long ways away from herd immunity, and to get an additional 60% of people with antibodies to this disease, it's going to be devastating.
Well, and that to that point, one of the things, another paragraph said that, see if I can find it here, nursing homes should use staff with acquired immunity and perform frequent PCR testing. Well, that's a challenge here, right? I mean, we don't have enough staff to do that have the immunity. And so that wasn't really feasible in what they put out, I don't think, at least for our area. Not sure how others would be. And we don't have the testing, the PCR testing available to do that. So I do think that it was a very credible declaration, and it's also signed on by physicians and some very credible people. I think it needs to be acknowledged, and I think that we need to use it, in our strategies. And again, I believe we are. I believe with what we're doing does line up with it, because it's going to prevent all of the things they spoke of that was harmful, that they were trying to advocate against. We, I believe, are against those as well, and shutting those things down and see the harm that comes. And so we're just trying to avoid that. Other comments, James?
Yeah, thank you, Chairman Reed. I'd just like to say, I'd like to point out a few points that many of the Board of Health have spoken about. One, I do believe we're doing some of the good points that you talk about, and we are certainly concerned about those other impacts that this is having outside of just the disease state. I think Commissioner Young makes a good point that it may not be feasible or practical to implement that entirely, because a vast majority of our population does have existing conditions that would probably be detrimental if they contract this.
Yeah.
Also, if we contract this in too short of amount of time with that natural immunity, if we all get it within the first 60 days, that could overwhelm our hospitals. And that's where we're trying to do somewhat of a focused protection, like you kind of mentioned, with the mask wearing and physical distancing, to still continue flatten that curve. When we talked about flatten the curve back in the spring, and the nation kind of did their thing, that we kind of felt in our minds that it may have just been a flatten the curve for 2 months. And that's really not the case. We really have to flatten it out until we can provide that immunity through the vaccine. And otherwise, what I'll just mention that hasn't been talked about is we still don't know how long that natural immunity will last. If it's similar to other coronaviruses and it lasts 6 to a year, maybe longer with some of the other ones that we've had, then we have a possibility of actually having to go through that again next year. And I think Commissioner Miller did a good job. I don't want to necessarily isolate everyone that would have one of those comorbidities or might be slightly obese or have a cancer in the past or over the age of 60 every 6 months for 90 days. I feel like that would not be practical or feasible. So I do think that we're taking the balanced approach in yes, we're trying to have things continue, but as safely as possible. And that's through some of those focus protection activities, maintaining 6 feet and that diligence about that, wearing masks when we can't do that, please staying home when you're sick. So we're trying to take into account, I think we've, certainly we haven't closed anything down that they mentioned in their letter there. I think we've just tried to, again, continue to reduce the number of cases that would hit at one time. So.
And Mr. Chairman, if it's all right, I'd like to just comment as well.
Yeah, go ahead, Jerry.
We acknowledge that this pandemic has created mental health challenges for many, many people. And we certainly hear a lot about the youth, and we are concerned about youth mental health. We're concerned about mental health for our healthcare providers. We're concerned about mental health for our elderly. And I can tell you many examples of stories that I hear from elderly people because of the lockdown that they've been forced to do. There's failure to thrive. And, it saddens me that we as a society don't place as much value on the lives of all of our community members, including our elderly, in this scenario. Every life is valuable, and any life lost to this, as well as to any mental health condition, every life we lose is valuable, and we need to take that all into consideration. And I do think our board has been reasonable trying to balance that, to allow things to continue, to do it as safely as possible so that the majority of our communities can be protected until we get to that point of having immunity.
Okay, thank you. Other comments on this before we move on? I find great credibility in it, and I think that it needs to be a part of our strategy. I don't find that they were speaking directly of what we're doing. In fact, I think, I don't know, but that they would be supportive of what we're doing to keep everything open to avoid all the things that they said was bringing harm. Any other questions or comments?
This is Bill Lake.
Go ahead, Mr. Lake.
I too watched the video and read through the material, and I think we're going to see lots of studies like this come out. And I think it's great that we've got some smart people out there willing to take the time to go and study this. But I agree with some of the things in there, and everything that you said, Commissioner Reed, was spot on. But something like this, I really believe needs to be looked at from a national strategy, and let the CDC and those folks in charge of putting out the public health stuff for the country take it from here. We can certainly take some of their ideas, which I think we're already doing many of them, but studies like this need to go through a very thorough peer review process before we just tell everybody out there in the public that we support it. Because there's a lot of things in there that I didn't agree with. And we have to be very careful that if we endorse something, even by talking about it, that the public doesn't see this as, hey, the study's out there, this is what we're going to go do. We learned that through here in Teton County when the last time we undid the mask mandate, the first thing that happened was several of the businesses just go, oh, we don't have to wear masks anymore. And they put signs out. So anything we do as a public health board, we need to be very careful about how we endorse or not endorse something. And I think with our meeting today, whoever's listening out there needs to understand that everything that they've heard here, and any board member that disagree, that's fine, but this not as a full endorsement of that study. Though there are aspects of it that certainly make sense and we are following. So thank you.
Okay, thank you. All right, we'll go ahead and move on then in our agenda to a report from our hospitals. We do appreciate each week the time that our hospitals take to give us a report. Again, as I've said before, that's the main focus of what we're doing, is to make sure that that is supported, and that they are continuing to have all the resources that they need to treat all aspects of our community, not just COVID patients, but anything that comes to them. So we will begin with Idaho Falls Community Hospital, Mr. Jackman. Casey, there, oh, you're muted. So there you go. We can't hear you, but I see that you're unmuted now. Mr. Jackman, while you're finding that and correcting that, we'll go ahead and move on to Eastern Idaho Regional Medical Center. Mr. Hoffenberg.
Good morning. Can you hear me?
Good morning. We can. Yep. And then we'll go back to Mr. Jackman when he comes back on. So go ahead. Thank you for joining us.
Okay. Absolutely. Thank you for having me. Just to give you an update on where we are specific to COVID, we have 26 inpatients as of 7 o'clock this morning. 6 are in the ICU, 4 are vented. That's down from this weekend where we hit 31 patients. In last week, as I reported to you all Thursday morning, we were at, I believe, 21 patients. That night, last Thursday evening going into Friday, we admitted 7 inpatients overnight with COVID. And so it was a pretty alarming change to things, which spurred a lot of conversation because the same jump or similar jump, not as big, was seen at the hospitals across the region. So in terms of where we see things, we are nervous and we hope that this is a blip and was a one-time jump in cases, and we don't see a sustained continued growth, because that would strain our resources to the point where we would be in a tough position as a facility. Staffing as of today is good. We are open for admissions, and we're able to take higher acuity patients from throughout the region. But the number of COVID patients being 26, that's a substantial increase of what our normal census would be with non-COVID patients in the facility. So, we've been working with the other hospitals in the district, with Rachel and Kevin up at Madison, with Casey at Idaho Falls Community, and even hospitals outside of the district, including Portneuf and Bingham, to come up with some different messaging as a region from the hospital's perspectives, with the help of Jerry and the health department, to put out really what is going on in our facilities, and to know that our situation continues to be tenuous. If things get worse, we are not well positioned, given our nursing resources, our facility resources, to handle a continued increase of patients with COVID, and the strain it's putting on our system and the health systems across the region is significant. And there was a point this last weekend where almost every ICU bed in the region was filled. And that is not a position anybody wants to be in. And, as one of the larger facilities, we have to keep our beds open and available for patients from Jackson, from Teton Valley, from Salmon, Idaho, because if we can't care for them, they have to go hours and hours away from their family and their communities to get the level of care that they need. And so we want to do all we can to remain open and available, but we kind of sit in a position where things could go south, and we want to keep the support of the board and the community to hear that we need to do all we can. So it's a continued messaging from the hospitals you should see in the coming days around what we think and our ask is of the community to continue to remain vigilant.
Thank you. One question that I might have right now is, a couple of weeks ago, you reported that you were seeing a greater acuity of patients, longer stays. I didn't understand why that was. Are you still seeing that?
You know, as compared to our normal population, a med-surg patient with COVID versus a med-surg patient without COVID is staying longer in the hospital. And I think that's due to a number of things. Not being clinical, I can only speak to what I'm learning from my physician partners, but one, we are still learning the best treatments and how to get these patients out of the facility. And I think that, really wanting to see improved oxygenation and to see their condition to the point where we feel comfortable with them re-entering the community is important. So I think there's just additional vigilance and oversight and concern. And also when you have a COVID patient, we're not just relying on our hospitalists or our intensivists. They're all being overseen by our infectious disease providers. And so you've got more members of the care team that are involved, and that can add to some of that. But, I think it's just, one, it's the resources and the care needs that these patients are requiring. But as we learn more, we hope to see that improve. But in our ICU, these patients are very sick, and once on a ventilator, it's a significant amount of time and resources they're taking up in the hospital. And so of my ICU beds, we are 1/3 of them are COVID, and those are ICU beds that are needed for patients with strokes, traumas, heart attacks, burns that. For a period over this last week, we weren't able to care for, and we did have to go on ICU closure. And so that's kind of our worry is the longer they stay and the more we have taking up those needed ICU beds, it puts us in a position as a region where we can't care for all the patients that we need to.
Okay, thank you. There are questions for Mr. Hoffenberg. We may come back to you all at the end. Commissioner Mendenhall, did you have a question?
Well, Mr. Hoffenberger, thank you for the information. The statement that you made that you did have to go on ICU closure, how long did that last?
It was less than 24 hours, but it was probably a period of 8 to 10 hours on Saturday where we were in the process of getting patients, downgraded out of the ICU, but we have still patients coming from the community, and we don't go on diversion. As a trauma center, you can never truly go on diversion where you say no patients can come in the door, because we always have to be available for our local EMS. But what we do is we then look at what are the patients coming from outside of the immediate community, from Teton Valley or from Jackson from there, and say, is this the most appropriate place? Because ultimately we will always care for a patient needing an immediate intervention, meaning an emergent surgery, a cardiac cath, a stroke intervention. Any of those patients, we'll never turn those away, but ultimately because they need stabilizing treatment. But we may not have a bed for them on the backside. So we want to make sure that we're not creating an unnecessary stop for them if ultimately we're not able to care for their inpatient stay. So we don't go on diversion where we close to all admissions, mostly because we have to remain open for our immediate community EMS, and then also, we have to see, is this the best place for that patient to come and stay? So, but yes, it wasn't for days and days, but it was for a period we were on closure.
Thank you.
All right, thank you. We'll go ahead and move on to Mr. Jackman.
Good morning. Sorry about that. I couldn't get my microphone to work.
Good morning. No problem. Thank you for joining us.
So during the weekend when David and his hospital were full in the ICU, we were as well. We could have accepted one more patient during this weekend. So realistically, there was one open ICU bed in Idaho Falls this weekend. Currently, I have 5 patients in the ICU with COVID. All 5 of them are on ventilators. I am down to 10 patients on our COVID floor. We've been up as high as 14. I'm currently sitting at 17, as I mentioned. We've been up this weekend, we were up to 19. We do have one COVID patient that we placed on comfort care this morning, which means he will probably pass away in the next 12 to 24 hours. One of the things that I think we need to express, we've been collecting data since COVID started. And one of the things that the government asked for is how many open beds do you have? And I think one of the more accurate pieces of data that they should have been collecting and that we should have been collecting all along is how many patients can you take care of? There's a nationwide nursing shortage, and even with the nursing schools around us, there's a nursing shortage in this area. This morning, our hospital could accept 5 medical patients, 2 COVID patients, and 1 ICU patient. So I can accept 8 patients today, and then I am full. So things definitely are on the rise. I think what we're seeing in the community is COVID fatigue. Everybody's just tired of it. And when I, excuse me, when I report our statistics to you guys every meeting, I generally just try and present the statistics and keep my political view out of it. But I believe that the fatigue that we're experiencing in the general public is leading to some lax standards. On my way home last night about 7:30, I drove past a home that was having a party with probably 100 people at that party, which obviously they were not practicing social distancing or wearing masks. And chances are everyone at that party is going to be fine, but somebody affiliated with somebody at that party may not. As long as stuff like that happens, I think David and I are going to stay busy.
All right, thank you. Is there questions for Mr. Jackman? So we'll go on to Madison Memorial. Mr. McEwen, am I saying your last name right? I apologize.
You got it, Chairman. Thank you.
Thanks for joining us. We can faintly hear you, so if you could speak up a little.
I am going to lean in then. Thanks. This is Kevin McEwen. I'm the Chief Nursing Officer at Madison Memorial Hospital, and I'm privileged to sit in on this meeting for Dr. Gonzalez this morning, who's attending to Idaho Hospital Association duties. And so grateful for the opportunity to be in front of you. She does a great job of keeping us all informed on these regular meetings and her almost daily conversations with Jerry and others. And we in Madison County have appreciated Amy and Mark and Mike and others who have helped us throughout this process. For the hospital this morning, we have 6 patients, 1 in the ICU, the other 5 on our med-surg COVID wing. Their ages range from 38 to 83. And we have a surge capacity plan to be able to utilize up to 12 beds. And 6 is the most we have had at one time, and that we keep popping up to about that number. We've consistently had 3 or 4 patients over the last many weeks. As David and Casey mentioned, our biggest limitation is oftentimes staffing. And I think Casey put it well, is, you know, we can only do so much. It's not necessarily that all of our beds are filled. We have 4 ICU beds. All of them would need to be in utilization, and another 6 to 8 med surg beds. So, you know, as far as our testing capabilities and turnaround and our PPE capabilities, those are in fair to good condition, but our staff are feeling that COVID fatigue throughout, not just nursing, but our pharmacy and physical therapy, especially our lab staff who are on the front lines of collecting our swabs and processing those. We're doing about 40 tests a day at the hospital and another 40 in our clinics. And the university has opened up a testing center with express labs, and they're doing equal to that number, which is a great relief to us. And you can see that Madison is a hot spot, and but it feels like to me that from the university and the hospital perspective, we are managing screening and testing as efficiently as we can, and those resources, thanks to the health district and the state, have kept us in pretty good supply. We are still sending out a good portion of our tests to Intermountain Healthcare, who has the capability of giving us a good 2-day turnaround, and they're using the most sensitive PCR testing. We do have in-house capability, and we strategize that around inpatients and symptomatic and preoperative patients that we're trying to screen. So we have those capabilities, and it feels like we're doing everything we can. Fortunately, the surge in the community hasn't really changed our hospital occupancy significantly. Like I said, we've had, 2 to 4 patients pretty consistently over several weeks. We've hit those high water marks of 6 patients, and we have been able to transfer critical patients to both ERMAC and Idaho Falls Community Hospital when we've needed to, and thankfully they've had those beds and specialists available when we've needed that resource. So it feels like from a medical and bed resource, although we are tight at times, we're able to manage that, and our providers are working very effectively with each other to consult with those services. So we've just added a tele critical care to our community hospital, and that is in conjunction with Intermountain Healthcare. And they do every 2-hour rounding on every one of our patients. Every one of our ICU patients are assigned a nurse and a provider out of the virtual telehealth center in Salt Lake, and they're able to visualize our patients, see all the data, reports, imaging, and enter our EMR and write orders if necessary. So we have a great support for our hospitalists with intensivists, both locally that we communicate with if we're needing consult and transport, but we have a telecritical care through Intermountain Healthcare that's been a great benefit to help us to keep patients here so that we don't have to overload the ICU beds in Idaho Falls with patients that we're more than capable of managing. So that is my report.
Thank you for being with us this morning. Questions for Mr. McEwen?
Yes, Mr. Chairman. I was just curious, this is Commissioner Minor. Of those patients that you've had there in Madison, how many have you had to send to either Idaho Falls Community or ERMAC?
I believe that number is around 5. And that has been through all the spring and summer and now into the fall. So those have been spread pretty wide. We've only sent, like I said, I'm thinking 4 or 5 that I know specifically. And those were specifically for advanced ICU placement.
Thank you. Good question. Other questions for any of the hospitals?
Mr. Chair, this is Jerry.
Yes, go ahead, Director.
I would just like to ask the hospitals to help the public understand what the process would be if you get to your breaking point. We at Eastern Iowa Public Health, through our preparedness program, have been working with the hospitals for years and years, and can assist in the request of federal resources to come to our region through the Idaho Office of Emergency Management. I know early on in the pandemic, as we were planning, the challenge is that our entire nation is experiencing the same thing as we are here locally, and those resources were not available. The physical resources that are available is one thing, but again, they do not come with staffing resources. So can the hospitals please just share with us, we've talked in general about surge plans and how you can shift things around, but at the point in which you can't move things around, what does that look like for us as a region?
This is Casey. That's a good question. It's something that we talk about on a regular basis with our physicians as we've been fluctuating in a higher area than in the past. Obviously, if I don't have room within my hospital, or I don't, more accurately, I don't have enough nurses to care for the patients, I'm going to do what I can to get additional nurses here, whether that be hiring travelers to come in and help us. And those travelers are incredibly expensive, but possibly needed. And the reason they're expensive is the supply and demand in the nation has created a market where a nurse can make in 3 months what she could make at a regular job in a year. And so they're very expensive to get here. But if I got to the point where I couldn't admit one more patient, obviously I would call across the street and see if Eastern Idaho had room. And if they don't have room, that patient's going to have to leave town to an appropriate facility. I know that Bingham and Portneuf have both been on divert and have actually been sending patients up this way. The last patient we received from Pocatello, they informed us that St. Luke's, Twin Falls, and Ogden each had only a couple of COVID beds available. So I'm not sure where those patients would go, but we would have to see what we could do to safely get them transported to a higher acuity facility.
Mr. Hoffenberg, can you respond to that as well?
I'm sorry, could you repeat the question?
David, it's Jerry, and my question was, in the event that the hospitals reach capacity, have done everything they can to surge your resources, and there's no federal resources that are able to come to our aid, what does that look like for our region?
Well, I think that there's a few questions there. So when you say if we've maxed out, meaning we've gotten every bed, every nurse that we can to work and to take patients, if we can't then accommodate, we either would do one of two things. We would work with the hospitals in the region to look at where do COVID patients need to be treated? And we'd go into an emergency operational type of system where, we would say to Madison, hey, what patients can you take? We have these non-COVID patients. Can we lateral transfer those patients out so we can accommodate the higher acuity patients in Idaho Falls, assuming that Idaho Falls Community and ERMAC can better staff than some of the smaller facilities, and we would want to kind of be the focal points and pool our resources the best we can. You know, bring in ICU nurses to the main centers and care for those higher acuity patients where we have the best resources. If at that point we've maxed out our ability to work jointly together across the systems, then we would have to send patients outside of the region. But you know, I can't say that what the end point would look like, because we're not there today, and there's obviously some levers we would pull between now and then to work differently together and to bring in resources more than what we have currently. You know, for HCA, my corporation, you know, we are working with our hospitals in Utah, because if you look at our hospitals, we are the vast majority of the COVID population, and we have plans ready that if we need to, we will pull nursing resources from Utah to help with the situation. And we would pull those levers before we would start just saying we can't do any more and we're done taking patients. So it's a hard question to answer, because there's a lot of things between now and that point that we would be trying to execute on to try to care for the patients locally the best we could.
Yeah, I agree with the other two gentlemen. There's a lot of variables in place that we would have to look at that moment in time, and the other patients we have within our facility that may be able to just be discharged safely with home care or to a care center or wherever to give us some hospital capacity. You know, Jerry, you know, mentions that, you know, federal support and help in the spring, you know, they were offering to set up a tent with all the equipment, but it didn't come with personnel. And that was a challenge. It's like, well, we can have a makeshift hospital set up for us in our communities, but if we can't staff it, how do those resources help us? So I think that what you're hearing from all of us is that although we're worried about bed capacity, we're much more worried about staff capacity and resources such as that.
Thank you all. And I would just also mention something that Casey touched on earlier, and we touched on it last week, that on our data dashboard, we certainly have been representing hospital capacity, which does show physical bed capacity. And we have had multiple conversations. We at Public Health have had multiple conversations with our hospital partners of trying to get better data of how we can really show what we realistically can take care of in our hospitals. So that staffed capacity that was mentioned earlier. So we're continuing work on that. That's not just a simple number to pull out of the air either. And for the hospitals, it changes hour to hour. So we're continuing that dialogue and are doing what we can to be able to give a truer picture of the hospital capacity in our region. I have one other question. Sorry, Mr. Chairman.
No, go ahead.
I don't know, gentlemen, if you were planning to stay on the line as we talk about our response plan, but certainly a lot of it does hinge on hospital capacity. So I'm just going to throw out, as we talk a little bit later, for our high risk level, the orange level, and the metric that we have used previously of a rate of 50 per 10,000 for our region. To me, that feels like way too high of a number now, as we now have some experience and we're bumping up to the 30 per 10,000 mark. Can you just tell me your thoughts on just that number alone? And I don't want to get in at this point into any of the mitigation strategies, but I'm just trying to get a good sense of, now that we're here at nearing the 30 per 10,000 mark, is that a trigger point for our hospital capacity?
Yeah, so when we're talking Madison County, it's always interesting because I think our population count doesn't always include the 10,000 plus students that really needs to be in that denominator, not just the numerator of cases. And so oftentimes the statistics aren't real for our little county. Certainly we're jumping up and adding that denominator of students into our play still has us way further ahead than we would like to be. But I do think that there needs to be, we have greater capability. We know how to manage this. For the patients, I forgot to mention this, that David kind of reflected this, but our ICU patients do stay considerably longer. For ours, our ICU patients are 7 to 10 days, and our med-surg patients are 3 to 5 days. We're able to get them in, kind of manage them, give them some of those medications that we have available to us, and get them out the door in 3 to 5 days. So, you know, that was not true early on. We were keeping patients much longer just out of concern, but it does feel like we're managing our inpatients a little more effectively than we were even 2 months ago.
Mr. Chair, I have a follow-up question to that.
Go ahead, Mr. Lake.
Kevin, thanks for that update. How many of your patients are BYU Idaho students?
None today, and very few that we've had. They are young and healthy and have not required hospitalization. In fact, Jerry may know exactly. But I'm thinking we had a couple early on, but most recently, none of the patients that we have been students.
Okay, thank you. Mr. Jackman or Mr. Hoffenberg, would you speak to your feelings about where that number is? Is 30 a place where you're feeling that it's a pinch point, or can that number, where should that number be?
You know, it's hard to place a number because it depends on what else is going on in the facility. And so, I mean, you know, I look at our ability to staff and handle our total number of patients. And, you know, this last weekend, I think we hit an all-time high census in the hospital, and that's why we went on closure. So it's not just, you know, COVID versus non-COVID that I'm focusing on. It's my ability to staff all of my patient needs across the facility. And I'm sure Casey looks at it similarly. So it's hard to put a number on it. I mean, with it being the highest number of COVID patients that we've ever had, that number is alarming. But if I had 30 or even 40 COVID patients, but I was down my census in other place and up with other patients, I could handle that.
Yeah, I would agree. I think it is hard to quantify based on the number of positives, because I think the number of hospitalizations is probably a more accurate indicator as far as where we're at. You know, we could have 40 per 10,000, and if those 40 people were responsible and quarantined and stayed away from people that were at risk, our numbers probably wouldn't be bad. And we have a surge plan as well that we have not instigated every possible move. We haven't even looked at canceling elective surgeries yet to free up nursing staff, but you know, we may be put into a position where we have to do that. But as it stands right now, things are tight. But we have not to my knowledge, there hasn't been one COVID patient that's had to leave this area because we couldn't handle them.
Thank you for that. And again, I don't know if you're able to stay on as we discuss our plan a little bit later. As our plan is based, it is based on hospitalizations that we would anticipate coming from the number of positive cases. And it has held very true to the 4% that we had anticipated early on in the development of our plan. The rate is just how we backed into how many hospitalizations that would equate to. So thank you for that. And also just for the public listening and for our board, the hospitals care for more than just COVID patients within our health district. They care for patients outside of our health district, in addition to all the other patients that they're caring for all other illnesses. So.
Yeah, thank you. And we realize that that's the capacity we have to maintain, is to be able to treat all patients. So thanks again to the hospitals for that report.
Mr. Chairman.
Go ahead.
Mr. Chairman, before we leave that, for anybody that's listening in the general public, I hope they get a feeling of confidence with our hospitals that they are prepared and they are managing. And when we don't do our part and we overload them, we're putting them at risk. And right now, the comments that I hear from the hospitals, they know how to manage this. But if we put them in a circumstance, which we seem to be a little bit, or a lot, we put them in a very difficult situation. But I want the public to know, I personally, for all three hospitals that are reported here, have confidence that they know what they're doing. They know how to manage this. They have diversion processes in place that they don't want to use. But man, I hope when people start to say, well, how many hospital beds? These poor gentlemen that had to give her that report, they can't pin that down. It depends on what's happening that day. And so anyway, I just wanted to express confidence in our hospitals and managing the beds, but I also don't want to put them in a position where it's out of their control. But right now it's in their control and they're doing a great job on that. But we're not doing our part on this end, not the board, the public. So anyway, just a passing comment.
Thank you, Commissioner.
Thank you.
Thank you.
Thank you all.
All right, we'll go ahead and move on. We did have on our agenda today a discussion on mental health impacts, and we had planned to have Dr. John Landers with us. He was not able to be here today. We just found out late last night. And so unfortunately, we are going to have to move past that. We will try again to have him on next week and plan to be able to do that. We want to hear a report on what mental impacts are being had throughout the community, our district, due to COVID-19. And I appreciated what Director Rackhouse said. There are mental impacts on all of society, really, the young people, the older, and all of us in between. And for a varying amount of reasons, everybody has their reason of why it is impacting them in a different way mentally. And so we want to understand that, and we will plan to have that on our agenda for next week and hope to be able to have him here at that time. So we'll go ahead and move on then to the next item on our agenda, which is a discussion and possible revision of our regional response plan. I'll go ahead and turn the time over to our director and epidemiologist.
Thank you, Mr. Chair, but may I ask that we back up to item number 7 just for a quick update before we jump into the plan review?
Oh, I'm sorry. I looked past it.
That's okay.
Yeah, so we'll have our update and then we'll go into the discussion. Thank you.
All right. I'm just going to start. If you can see my screen, it has the picture of our website with our total cases as of yesterday. This is where we depict the active rate per county. You can see Custer County and Fremont County have both dropped considerably from last week, and that's good. But with that also being said, our small counties with their very small populations are just variable. And it is very hard to predict what's going to happen in a county from one day to the next that could significantly impact their rate. When I look at Bonneville County, we've hovered around the rate of 20 per 10,000 for quite some time. And as James and I were talking yesterday, that with schools opening back up, we really feel like that's a win, that we are doing things right, that people are doing their best to follow our recommendations and physically distance and wear masks. Is it perfect? No, but I honestly expected that rate to bump up a little more when schools went back into session. So I think we should acknowledge that as a success. Let's just go to each of our individual counties. And I'm going to have James review each of them as well as testing.
May I just follow up before you move on from that, because I appreciate that comment, and I do want to recognize the school districts have been trying real hard, and I personally really appreciate all of the work. I can't speak for all the counties because I don't know the situation in all the counties, but I know here in Bonneville County, the school districts 91 and 93 have been working incredibly hard. And I know the students have been very responsive to follow the measures that are recommended. The school districts have been requiring the face coverings. And I think that we see that it is helping them. I'm sure there's other school districts around that are doing the same thing. And I'm sorry, I can't speak to them, but I have been in school districts here and in the schools. And I really appreciate all the work of the school boards, the teachers, the superintendents, and especially the students and what they're willing to do. And so I appreciate what you said, Director, and I think that their work does show. So thank you.
So thank you. And I just want to highlight a few things. Normally we go over something fairly quickly when we do these updates but we wanted to take a few more moments and maybe show a few things that we can see here from some of the data. We're first looking at Bonneville's rates here, and the blue bars, I'll just reorient, are the incident number of cases that we were reporting that day. So this is really an incident or number of cases that we were reported that day. That doesn't take into account onset date of the illness. Onset date really is added by looking at the active rate, because we look at really those individuals that are not released from isolation, or those that are still within 10 days from their symptom onset. So that green line is our active rate. And as Director Rackow just mentioned, and you mentioned Commissioner or Chairman Reed, that we are pleased really even with the addition of school back, that Bonneville County, and I think it's through the efforts of those residents and the schools, that we've been able to stay, somewhat steady throughout this. It's similar to what you actually brought up with that report. We have not necessarily closed down. We've tried to engage people in going back to lives as much as possible, as safely as possible. And this is happening. I just want to say that we are concerned about every life lost, no matter whether it's due to COVID or another condition or a mental health concern. And we certainly don't want that. So we try to keep those rates as low as possible. I don't want us to be mistaken to say that we're encouraged by the number staying flat. We still are concerned about other lives lost, but certainly it's encouraging that we didn't increase rates. I'll come back to Bonneville potentially, but I just want to notice that there's very few gaps in our dates. There's fairly big blocks of blue, I'm going to say, right? There's that you can see here that really demonstrates sustained community transmission. And I'll say that Bonneville County has a population that helps. I'm going to contrast that, I guess, right here, and I apologize because it's a little, as I'm trying to do it remotely, it's a little jumpy. Clark County here is our next one, and I apologize that you can't see that, but it is Clark County. You can see partially due to their smaller denominator or smaller population, they're going to have a wider range in that variability of the active case rate. And as well as you can see, there's not large blocks of blue, it's fairly sporadic, which means, well, it's two things really. One, the population, and I'll show that in more detail as we go through each county, but also that the variability in the population, as well as not necessarily sustained community transmission, we see pockets of individuals getting exposed. Moving on, and maybe it's just easier if you control, it's probably, this one being Custer County. This is where we can start seeing really maybe more sporadic cases, and that meaning that the variation in their active rate is very hard to pin down. And we've talked about that a number of times. They are just going to ebb and flow because A, we don't have those blocks of blue or that sustained community transmission on a regular ongoing basis. And that's really due to Idaho's sometimes rural nature. We have the ability to isolate, especially in some of the smaller counties, quite well from each other just naturally. So we have pockets of families, and while that's true, we're seeing that same thing even in Bonneville County. There's just more pockets of families to continue that disease transmission. So we're able to isolate some of those. So we're going to see higher variability the smaller the population. I bring this up as we've talked about yo-yoing in and out of some of those rates before. So continuing on to the next county here, and I'm trying to remember Fremont, thank you. The Fremont, you can see as their population is increased above Custer County and Clark County, that it has a little bit more strength in the variability of those cases. We're also seeing a little bit more blocks of blue, not necessarily any days with gaps of transmission. So we're seeing some, and as we see that, I guess, more towards the right of this graph instead of the left, where there was maybe some cases in and out, we're seeing a more sustained active rate continue to increase. So we're encouraged as we look on the incident cases that there's maybe a few gaps in the last few days as we see that. That might mean to us that that rate will start coming down soon, and then there's not as much sustained community transmission. Going on to Jefferson, you can see that Jefferson is really, again, the population as it increases, we really start to understand what that sustained community transmission means. No block necessary in cases. You're going to see a gap on Labor Day on many of these cases. I'll just say that was around the September 5th or 6th. I can't remember. Many counties do not have any cases reported on that day. That was kind of an anomaly that we knew would potentially happen, as testing wasn't necessarily done very much on the Saturday. So at that time we were running about 2 days and we received very few reports on the Monday. But absent of that, we have seen somewhat sustained community transmission. I'm going to show that there's kind of two peaks there just a little bit starting in August. You know, the first few weeks of August, there was some, but there was a little bit higher degree of variability. Contrast that with now kind of this September 23rd peak that we're seeing there. And really in the 1st of October, there's still a higher degree of that blue blocks just being there and more consistent, sustained community transmission. We're not seeing gaps in that. With Lemhi, again, we're now going down into a little bit smaller population. There's not necessarily sustained community-wide transmission going on there. I would say recently there probably has been, but early on where we had those peaks, we may not have expected that. And that will just contribute to that yo-yo. The smaller population, the higher degree of that variability of the active case count. Or even if we used a different metric, such as a rolling 7-day average of cases that many national publications use, it would still show that variability in their rates. Moving on, this is Madison. You can see that throughout the summer, really up until the early part of September, they had very few cases and kept their rates low. We often wondered and even talked in this meeting previously of why that was. We still don't have a definitive answer. It probably is not one answer, but multiple ones. But you can see that this incident cases has continued to increase. We don't believe that the active case count will necessarily drop off due to that. As we continue to see high blue blocks grouping together, you're going to end sustained community transmission. There's a potential, if individuals don't use those mitigation strategies, to continue that rate increasing. I'll just mention that the first white line, if we can just scroll over to the left just briefly, Jerry. The first white line is the active rate of 20 here at Madison, and the second is 40. So you can see that we've been above as we scroll again to the right. Just to orient people, we can see that, again, that third white line is 60. So those numbers are just below that, the bar that they're indicating. So 20, the first white line, and 40, the second. Moving on, this is Teton County. Again, this shows really the high degree of variability that we have in some of the smaller populated counties that, as well as if they do not have sustained community transmission, they are going to have a little bit higher variability in that case count or the active case count that we use for those rates or metrics. We have in Teton County, as you can see, bumped above 10 at late August and as well as in July. But you can see that many days they did not have any individuals that were reported until recently, where we have actually had sustained case reporting from Teton County. And you can see that their rates reflect that now, going above the 20 mark. I don't know if the last one being the district as a total, you can see that our early there was maybe a slight peak in early August when we started to dip down, and then really probably some of the other other counties besides Bonneville, as we said, it's been fairly stable, has shown to increase the rates again. And we're getting more consistent solid blue blocks up into the incident number of cases that we're reporting each day. I wanted to pull that out to show, again, two things. One, when we don't have sustained community transmission, certain days, or really maybe a small pocket of coworkers or families with small population counties can really actually have an increase in our rate for that county. Not that the rate is wrong, it's just not a perfect way of looking at it where the population or those denominators are small, where as you get into counties that have a substantial enough population that can use that variability and reduce that variability, such as Bonneville, Madison, Jefferson, really, and as the district as a total, you can really count on those rates to be accurate of what we're seeing moving forward, and we don't get that yo-yo effect as much. I bring that up in preparation for our conversation later, as I know the yo-yo effect of counties in and out is a concern. And I can share more thoughts at that point as well, but I wanted to bring that up at this time as well. Do you have any questions regarding that, or any board members?
Well, as I look at it, particularly our whole district, it looked to me like, you know, when we started implementing some measures for mitigation, that end of July, 1st August, that then our numbers were coming down. I mean, it was showing a good trend. And then, as we had feared when school started, there's only so much you can do, right? And there's going to be some spread. I don't know. That's what it seems like what happened when the schools opened up.
Yeah.
But you don't know what that would be without all the measures being implemented now.
Yeah.
You would suspect much worse as we're seeing in some areas.
Yeah, I would expect, going back to the school conversations and the school's ability to help us with transmission within that setting has been aided in keeping those rates down. I would expect that they would actually be much higher. I do think that there's other variables potentially in play. We've talked about it a little bit, where we get pandemic fatigue or COVID fatigue, where we recognize that it's not always easy to remember your mask or and we have a desire to be normal as much as possible. And due to that, I think we did see a reduction in cases as we put in measures kind of in that July timeframe, and we started to see those results. And as pandemic fatigue sets in, as well as schools, as well as maybe a collection of individuals around Labor Day, we did see an increase in cases.
I had one more question for the update, and then I invite board members. I don't mean to dominate the questions, but so I invite you to ask your questions. But and this is maybe for Commissioner Mendenhall. Did the Madison School District, do they do a potato harvest break?
Yes, Mr. Chairman, we're in that right now. I believe school resumes on October 13th, I believe.
I thought that was the case, and I guess I'm hoping that we see that maybe that helps bring things around. Would you expect that, James?
Yeah, so I think if I may, what we see in schools right now is that in the controlled environments of classrooms, they're doing a very good job of wearing masks and trying to physical distance as much as possible and where it's feasible. And that's helping to control the spread amongst classmates. Where we're seeing schools being impacted is honestly within extracurriculars, sports and other type events that they're putting those kids maybe that aren't wearing masks together. So classes, for the most part, we're seeing very little spread with, even if there's a case in that between a teacher and a student, or even between students, because they have good protocols with masks and physical distancing as much as possible. It's more difficult on a soccer field or a football field or a volleyball tournament to be able to do that. And that's certainly impacting schools, as well as then home life as they're bringing it back to home.
So I would just say to follow on to that is, we're hopeful that we will see some reduction, but unless kids don't continue their interaction and activity with each other during that, I don't suspect we'll see a reduction.
Yeah, thank you for wrapping that up. Yeah.
Now, maybe that was a little optimistic on my part. I just hope we see anything that'll help bring that number down. Are there questions from the board as far as the update?
Mr. Chair, this is Bill Lake.
Go ahead.
Yeah, James, thanks for the information. So my question is, it'll come from, the devils are in the detail. When we look beyond the case rates at each individual case, are we seeing any trends in there? Or, for example, you talked about the schools. You were able to somehow conclude that most of the transmissions aren't coming from the classroom, but extracurricular activities. When you look at all the cases, is there anybody doing an analysis to try to see if there's some common link between where these transmissions are occurring?
Yeah. And I want to do one more point on your question, Commissioner or Chairman Reed. We are optimistic as well, because while we say that there's good control, I think busing also plays a role in that sometimes school transmission, because there's not as much direct observation of, an authority figure, we'll say, to help keep those kids physical distancing and mask wearing as much as possible. So I share your optimism, and we're hopeful that it can help with that. It came at a good time, and we'll see if that can help. To answer your question, Bill, yes, we try to do that. Certainly, we have many staff that are working on doing these rates, as well as working with schools, as well as doing just normal disease investigation and contact tracing, where we don't get as much information or be able to dig into the information as much as we would like at times. That being said, we don't always get information from individuals either where they may have contracted it from. Sometimes they just don't know, and that's where that community transmission comes in. So I don't want to oversimplify this, but the trend is that we see individuals having close social contact with sick individuals. That's where we're getting increased rates. So wherever you have social interactions within 6 feet, whether that's work or school or within families, we're seeing an increased case counts with those. And I know that seems oversimplification of where we're seeing it, but we're seeing it all in those gatherings where individuals let their guard down potentially and get into that routine nature of, I'm with this person every day, I'm going to kind of let my guard down slightly. And we see it amongst coworkers, we see it amongst family members certainly, and we don't expect household members to try to reduce that, but extended families sometimes getting together, as well as coworkers, and then, like we said, some of those extracurricular activities.
Thanks, James. A follow-up question on that is this 15 minutes for a close contact, that if you're within close contact within 6 feet with an individual for 15 minutes, how is that 15 minutes? Is that come into play here? Have you getting much information about people that might say, yeah, I got it, and I was talking to so-and-so, but they weren't necessarily there the whole 15 minutes?
Yeah, I think it's less for that, because sometimes when we talk to individuals, we're certainly asking them if they've been in contact with somebody that is sick. And that's why I say what we're seeing is a trend of people being in contact with sick individuals. So if they're not being told that someone's sick, or they may be right before symptom onset, that individual doesn't know. So anytime that you have a close interaction with somebody, you're increasing your risk. I will say that the risk is not zero if it's less than 15 minutes. We talk about that a lot, that this 15 minutes is kind of this bar that you have to hit to then actually be exposed. And that's not inherently true. That's just the bar that we set for the exposure to be long enough that we would ask you to isolate. That you would be exposed enough that you would have a high enough risk to contracting that and spreading it to others potentially. Certainly, if you have, especially the closer the contact you have, and without any of the other mitigation strategies, the closer you are for that individual for less time, the more risk you have. So we see individuals having contact with other sick individuals as that's just, I know that's kind of an oversimplification of it, and maybe that's not exactly answering your question. That happens in family groups, that happens at work, that happens, in a lot of the groups that we attend and associate with on a regular basis. That's why we really appreciate and strive to really get people to stay home when they're sick. That's one of the best mitigation strategies that we hear on a regular basis, that they thought maybe there were symptoms of something else or they didn't know exactly what it was. We really just ask that individuals, if you're having symptoms, and I know that symptom list is quite extensive that are associated with COVID, but to contact your provider and talk about getting a test so that you can know for sure and maybe not spread it to others.
Okay, thank you, James. And if you'll indulge me, one last question, or actually more of a statement, and I don't like putting Brent on the hot box here, but we had several comments that came in about mask wearing at the Madison schools. And some of them had several examples of cases where the teachers weren't, enforcing it. And in fact, it seemed like some of them, they might even have been discouraging the wearing a mask. So I think that we need to really take a hard look at just how our community leaders across the board are following our recommendations and guidance. And we need to be maybe thinking about writing letters to individuals that we know or we hear of that are not taking this seriously so that we can get their attention. So with that said, thank you.
Are there other questions from board members?
Not a question, Mr. Chairman, but I think maybe, Bill, you might want to understand, Chairman Reed sent an email to the school district and addressed that and included a couple of the emails or an email. And yeah, you're right. The school districts and the administration at BYU Idaho, they all do what they can do. They do have a mask policy at the school district, as perhaps a lot of them do in different counties. But I listen to all of this and I read all of these emails and the different opinions and the different ideas, and even in the medical world where it's in conflict. And, it's going to come down to some personal choices. What are we going to do? And you've said that yourself, Bill, just out of courtesy to someone else. Anyway, yeah, I believe that you're going to see more aggressive things come to those organizations. We, even in our plan, we don't take the stand of telling school boards what to do, and we can't. They're elected officials. But we can certainly let them know. One question I might have, Mr. Chairman, if I may, real quick.
Go ahead, sure.
Thank you. Is there a correlation, James? Do you know a correlation between, say the numbers drop in Fremont or in Teton, but they continue to go up in Madison? Is there a correlation in the number of tests that are being administered? Do we track that at all? When I hear a report that there are 40 tests at Madison Memorial, 40 tests at BYU Idaho, and 40 tests in the clinics, does active numbers, would that by chance, if there are more testing going on in a county, wouldn't that result in more active cases?
So yes, if there's more tests, if there's more sick individuals.
No. If there's more testing, if you do 150 tests in a county and you do 20 in another county, the odds that there's going to be, and we have that percentage of positive tests. I guess my point is people are sick, they stay home, they don't get tested. And we do have a little bit of a culture here that there are people getting tested because they want COVID. And that's a whole nother topic. But is there a correlation between the number of tests and the rise in active cases?
So I'm going to answer that again, just briefly, but Jerry has brought up actually a graph here that the state has where they are able to gather the number of tests, which are shown in blue for a week, as then the percent positivity as the orange line there. or what appears to be orange to me. What I would say is that you see a slight correlation to some of that. But that's where I'm going to say that with a caveat. Right now, the recommendations from local public health departments in Idaho, because of some of our restraints in testing everyone, we just test and encourage to test symptomatic individuals. So if more tests are being conducted, that we should correctly assume that there's more sick individuals. So back to your example, if we conducted 20 tests in one county and 40 in another county, the 40 is just more sick individuals in that county. So that would probably equate to more cases. So
okay, so I see this.
Yeah, if we
I see the 700. Go ahead.
I'm sorry. If we were to do universal testing of asymptomatic individuals, yeah, I think the percent positivity would mean more at that time if we were doing kind of surveillance type testing. But when we're just testing, symptomatic people for the majority of those tests that are happening, we would expect that the percent positivity really just follows the number of tests.
Okay, so if I might, right now we have on screen Madison County, great example. On September 12th, we were running weekly tests of about 200. And on whatever date that is, I'm blocked in the way. But anyway, September, whatever date that last date is, we're up to 700. So that's a 500 increase weekly. Would you please put up either Fremont or Teton or Bonneville? I don't care which one.
Well, and if I may, just to clarify on this one, the line is actually the number of tests, I believe. And
correct.
Oh, no, excuse me. The bar, it's still the same. The bar is the number of tests.
Yeah. So just Bonneville. So here's my point, and I'm not defending what I'm trying to do is if we're going to rely so heavily on active cases, I want to make sure we're accurate. Yeah. Looking at Bonneville, yes, 800 tests in correlation with population, which has been pointed out to me that, we can't, population, Bonneville's 4 times the amount of Madison. The number of tests, they escalated their testing on September 5th, and their testing has actually gone down. So they're not doing as many tests. And I don't know if I'm making sense, but we got to make sure that we're doing apples to apples. And we're not saying, oh, Madison is through the roof. We put up Teton County. Have they gone down in their testing or are they back up?
So I just want to make one more point here. Actually on Bonneville, if we could stay on Bonneville for just a minute, we did actually more tests on this week of September 19th and our numbers went down a little bit. So that would actually go back into the face of the correlation of just the number of tests increase the cases. So we increased the number of tests and we stayed approximately the same that week on our active case count.
Okay, so they have increased. They're staying steady with a high increase of testing.
Yep. All right. I just want to say that this is a snapshot of some of the testing that is being done. We're not able to gather all tests that are completed either. There's many providers that have rapid antigens in their office that we don't get both positive and negatives for. So we don't have a true number of all tests being completed in all of Eastern Idaho.
Okay. All right.
But we can look at that helps me. We can look at Teton if you'd like.
Or Fremont, either one.
So again, Teton cases have increased just in this last week, but for many weeks you can see by the blue bars here that they were conducting the same amount of tests.
Yeah. Yeah, and ours went up high. We do have a culture here of plasma seekers. And that's why I wondered if people were testing more for plasma seekers and the percentage is higher. Okay, enough. I don't want to take the rest of the commissioner's time. I just was curious. We have the data. It's there, so I can see that. Okay, thank you.
All right, thank you.
Chairman Reed, This is Commissioner Young. I do have one question.
Go ahead.
And yeah, James, I'm just curious because really in the nutshell, to me, the bottom line is what's happening with our hospitals. Even though we have this high rate for Madison, has the hospital admissions for Madison increased with the same proportion?
Yes, and maybe it's time to, we'll show here. So we have experienced as a district very close to our 4% hospitalization for known COVID cases that are reported to us. In fact, it's actually just increased slightly over the last month since we've redone it. So it's now at 4.2%. And Jerry, I don't know if it's not sharing it right now.
Sorry.
We'll share a screen here where we calculated actually the hospitalization rates for each county. Now, again, I want to just preface this with smaller denominators at times can lead to higher variability. And so at the end there is the 4.2% at that bottom line on this little Excel spreadsheet that we put together. Bonneville being actually at 5.1% hospitalization rate. So that is the number of individuals going into the hospital divided by the total number of cases for that county. So just Bonneville County residents that went into the hospital, 5.1% of the cases go to the hospital. Clark, and this is where I'll say that there's a higher degree of variability, the lower number of cases, is at 10.8. Custer, 1.5%. Fremont, 4.3%. Jefferson, 4.4%. So really staying close to that average. Lemhi, slightly higher, 5.9%. Madison and Teton, both at 1.9%, actually, hospitalization rate. I would equate that to a few things. One, the demographics of the individuals that are getting sick within those counties. We know that Madison, with the higher number of student population, which I'll just mention here, because the representative from Madison Memorial talked about briefly not accounting for the school-age children. We've been assured, and Mayor Merrill has looked into this from Rexburg, as well as Commissioner Mendenhall, that students are counted in the census population. To what extent, it's a little bit unclear. So there's certainly room for error there, but as much as 10,000, we're not confident in that. They are certainly underreported. That's actually a problem across the nation in university or college towns, but to what extent, it's hard to put a number on. So we go off of the number that we know is accurate as much as possible. So Madison County being at 1.9%, as well as Teton, I don't have the information in front of me to have, chronic disease states in each of those counties, or the average age of the individual within those counties. But I would assume that they're lower for both of those counties, as well as we do know from previous times when they release rankings for healthy counties, both of those do sometimes rise to the top, partially due to their outdoor recreation, sometimes due to their lower chronic disease states, as well as the age of the population. So all of that factors in, Commissioner Young, into that. So I would say Jefferson is on par, really close with the total overall district. Bonneville is slightly higher. There's, again, a little bit of variability in the other numbers with the smaller population counties, but Madison, I could safely assume it is due to the lower age of the population that is getting the disease. Does that answer your question, or Commissioner Young?
Yeah, yes, thank you, James. I appreciate that. Yeah, and can I add, I just want to thank James. I think when you devised these metrics and that was the number you calculated was approximately a 4% admission rate, didn't you?
Yeah, as we looked, we anticipated it going into that 4% range. When we first initiated the plan, we did say 5%, but we thought it would go lower based off of some of the other state metrics, as well as other states that were slightly ahead of us in this response. So yeah, the percentages proving to be correct, and we're seeing the hospitalizations associated with the cases.
Okay, yeah, thank you. I appreciate that. I think you've done a fantastic job at forecasting what would happen with rate. So thanks, James.
Thank you.
So, Mr. Chairman, just a couple of other updates before we actually get into the dialogue on the plan.
Okay, and before we do get into the dialogue on the plan, I'm going to take a 5-minute break. So go ahead.
I just wanted to report on testing. Last week, Governor Little did announce that the state was being allocated over 500,000 rapid antigen tests from the federal government. They've been received by the states. They've been being shipped out, the first allotment, to the public health districts across the state. Our first shipment is about 4,400 of those rapid tests. And the priority that was given for these tests is for schools, for staff and teachers. More recent conversations with the Department of Health and Welfare, they're looking also students now. We are quickly trying to gather all the details that we need as far as how they can be used, how they can be distributed, reporting requirements for those tests. They do have to be conducted at a certified laboratory. And so we're trying to quickly develop our plan of how those tests will be distributed throughout our health district region to help support the schools. The distribution is over a several month period, and the state's testing task force is working right now to prioritize how they see the distribution of future shipments of those tests going. So we don't have all that detail now, but I just want everyone to know that we're quickly trying to get a plan in place to get those tests out to support schools as quickly as possible. Public health has not been a provider of testing. In the state, that's generally the case. There's some limited capacity to do rapid response for outbreaks. But generally, public health is not the provider that conducts testing for COVID-19. So we're looking to work with our healthcare partners that are already in our communities to see if they can assist us in targeting these extra testing resources to our school populations. I also just wanted to mention that our Tableau site, our data dashboard, we've talked about that this morning a bit. It continues to evolve, and we understand the interest for people to have data to help them make decisions, and we'll continually try to improve that site based on requests that we get and that we're able to accommodate. And some of the things that we mentioned already is trying to give a good representation of staffed bed capacity, looking at all hospitalizations of our hospitals, not just the COVID patients from our health district, some weekly hotspots. Something we already talked about earlier is where people are being exposed, if we're able to identify specific locations. Also, city of residence of cases. And I know I've had many conversations with elected officials, city mayors in particular, about their desire to have that information to more appropriately target response efforts in their jurisdictions. But we get that request from the community as well. Part of our challenge is that some of the information that we include right now on the detailed case information line list could potentially identify individuals, and we have to be very, very careful not to violate HIPAA and release anything that would potentially identify someone violating their privacy. So we're looking on all of that, and we'll continue to try to make improvements to the dashboard to share information that people are requesting to the best of our ability. Just one last thing that I wanted to mention, it has to do with contact tracing. Certainly as cases have increased in our health district in recent weeks, it has stressed our contact tracing ability. You've heard we have as quickly as possible, ramped up that capacity. It's not instantaneous. And at time we've had to redeploy in other health district staff to assist in that effort to keep up with that, the increased cases until we can get, increase our staffing for the contact tracers. It's hard for us to predict what it's going to look like 2 weeks from now, to make sure we have enough staff already hired on to address what we might anticipate in an increase in cases. And we certainly just don't want to have staff sitting around twiddling their thumbs either. So it's that balancing act of acting early enough to make sure we have capacity, and having staff doing meaningful work. So that's a continual effort that we work on every single day. As far as contact tracing goes, we mentioned in the past that sometimes it's very difficult doing an investigation on a case. And we're not always successful in making contact with a confirmed case of COVID. Right now, out of our 620 active cases, there are 18% of those, or just over 100, about 114, that we have contacted multiple times through phone calls and through texts that have not replied to us. So 18% as of today of our current cases that have not returned messages to us from us for us to be able to conduct investigations.
So those still get reported though?
Yes, they still get reported. Can you explain how that works?
Yeah, so we certainly still report them based off of the address that we receive through the report from the provider or lab company. Certainly it would be our desire to actually have a self-report of where they are, and if that address is accurate. Certainly people move as well as change numbers. We do our best through every avenue that we have to get numbers or to contact these individuals. I will say that if we don't have an onset date for those cases, we just go off the lab collection date for the active case count. So without lack of information, without that other information, we go off the most accurate one we would have, which would be the lab collection date, because we don't guess on necessarily when they became symptomatic. So
makes sense.
So one question I would have before we leave this update is, you referenced the demand on your staff, particularly the contact tracers, but it applies to all of you. I haven't known how you've been able to keep up the workload that you have. You guys, East Idaho Public Health, reports 7 days a week. I know you're working 7 days a week. I know you and many of your staff, but particularly you and James, are working 24/7 in your mines. And I have become continually more concerned for the load on you and your staff. I guess I would just, as a member of the board, I just would like to know if there's anything we can do to help with that load. If certainly sometime there has to be some disconnect and some ability to take time off. How are you managing that? How much longer can we sustain this type of workload? Just help us understand if there's concerns we need to have.
Well, I certainly appreciate the concern. And yeah, it has been a lot for all of our staff. We are, between James and I, trying to make sure each other gets some days off that they are disconnected, because we need to have that physical and mental break. There is a lot of burden on my shoulders for what we do within our health district and the concern for our residents. It doesn't turn off at 5 o'clock. And I do appreciate the board and how we've initiated the public comment and the board responding to a lot of those comments that come in. They're very time consuming, as you know, but just the continual touching base and being able for us to provide you with information. I don't have a great answer. It's been 8 long months. I don't see the end yet, but we are trying to do what we can to manage internally, bringing on new staff where we can. But our epidemiologist, as well as the contact tracers, it is 7 days a week. And I just want to say kudos to our staff. And I will also say that there's very little that we can do financially to reward everyone for their extra work.
Yeah, that's been concerning to me as well. Well, we appreciate everything you're doing very much. And I guess I would just say to remember, because I know you take such a burden upon your own shoulders for the entire district. And you and all of your staff, just remember that and be confident that you are doing all you can do. And sometimes that's all we can do. And I believe, well, I know that you guys are to that point. You're doing all that you can do. You need to understand that it's the responsibility of individuals and other elected officials and community leaders to do what they can do. And we see that happening and we appreciate it very much. But please do not become overburdened, because you are doing all that you can do. And we are always here and mindful, and so let us know. With that, I would like to ask for a 5-minute recess or so. So we will come back approximately at 10:17 or 10:18, somewhere in that neighborhood. And so that we're all fresh to be able to begin our discussion of where we go from here. So take a break here, everybody. Thank you. All right, thank you, everyone. We will go ahead and continue our meeting. I think we've received a lot of good information this morning that will be helpful in our discussion, and look forward to hearing your thoughts. So I will go ahead and turn the time again over to our director and our epidemiologist to discuss their recommendations for the plan.
So thank you, Chairman Reed. And from day one, well, I'm just going to go back to July when we put together our plan for Eastern Idaho Public Health, when the responsibility of this response was given from the governor to the local public health districts. And at the time, we did the very best with the information that we had to put together a plan that we felt was appropriate for our health district's region. We still feel like we have a good plan in place, and many of the metrics that we chose are playing out to be accurate with the hospitalizations that we already talked about. As was mentioned earlier, there's a lot of different metrics that can be used. New daily cases or a 7-day average of new daily cases is one number that's used a lot. But again, our goal was not to focus on the cases. It was to focus on the hospitalizations that would result from a specific number of cases, to be able to put strategies into place that could keep things slowed down enough and manageable enough to maintain hospital capacity, while we know still people are going to get infected, but to keep it at a manageable pace. With that being said, as we put together our plan, some of the mitigation strategies did look very much like what we had experienced with the governor's stay home plan and then the reopening up plan. Now that we've had 3 months of experience within our health district, certainly we want to have some dialogue about this with you. And I'm going to pull up on the screen, and I apologize that it is not a great formatting. We had to un-PDF the document to be able to edit it as we're having this dialogue today. We have gone back and assessed, is what we're doing the right things to be doing? And I don't think there's any perfect answer to this. And so I want to first start with our green risk level. And I just wanted to say, because we've had conversations with a lot of people over the last 3 months. One individual scientist that provided information and had a conversation with us here made the point that regardless what we do, whatever mitigations we take or don't take, we're going to see a spike, and it will eventually go away. What we do could have impact on that, and what we don't do could have impact on that. But one way or the other, we're going to see a peak, and it will eventually go away. For public health, regardless of what else, our message remains the same. The way that we're going to slow this down and protect ourselves and our communities are these 4 things right here on the screen. Stay home if you're sick. Maintain physical distance from people outside of your household. When you can't do that, wear a face covering. Use extra hand hygiene measures. And the last one, carefully monitor your health, goes back to stay home when you're sick. If we do those things, we're going to minimize disease as much as possible, maintain hospital capacity as much as possible, and get to the other side of this pandemic at some point. As we look at the metric that we used for the moderate, and again, it was based on hospitalizations that we would anticipate coming out of cases. One thing is that we know that there are people that never get tested, and so there's likely a lot more disease circulating in our community than what is represented in the numbers that we report every single day. You've heard us talk about multiple times the challenge with counties with very small populations and the variability that it's going to have because of their small population. And any level that we go into, there's the potential of bouncing in and out because of that very reason. We've talked this morning about challenges in accurately identifying what the hospital's bed capacity is and what their staffing capacity is. It's all very fluid, and for many of these reasons, it is very challenging to pick a specific metric that is going to be the right metric. Through all these conversations, we still feel very confident that the metrics that we have chosen, the active rate is equating to hospitalizations as we had anticipated. And so for this moderate level, I would not propose any changes to that as far as the active rate, basing it on 10 or 15 as was designated for a couple of counties, to continue to do those measures that are within our control. And when we look at the list of the mitigation measures, the two things that our board has taken action on is to issue a health order requiring people to wear face coverings in public when they cannot physically distance from others. And then we've also put restrictions on events and social gatherings. The basis behind those restrictions is, again, guidance to be able to help people maintain the 6-foot physical distance. The other things that you see in that list, vulnerable population should take extra precautions. That has been our message from day one. We do communicate with schools. We provide them information. We provide them recommendations. But we all know that it is up to the school boards to make the decisions for their school districts. The other things in here, telework and minimize non-essential travel, are those good practices? Yeah. Is there anything that we as public health can do to manage that or require it? The answer is no. And my recommendation is that those two items be removed from this list, and we focus on the public health actions that we can take, that our board can be responsible for, that promotes minimizing the spread of the disease. Even with that said, with the things that we can do, while our board does have the authority to issue health orders, we all know that we don't have the authority to enforce them, and that there is only so much that our Board of Health can do. And that has been challenging throughout this entire pandemic, that we give recommendations, but we can't force people to do things. Outside of this pandemic, there's a lot of other public health concerns that we have, that we provide recommendations to people, but again, we can't force them to take those recommendations. Our mission in public health is to prevent disease, disability, and premature death, promote healthy lifestyles, and protect the environment. Those first two, prevent and promote, are things that I think is within our responsibility as a health board for the face coverings and the recommendations of that we know face coverings can help minimize the spread of the illness. I've also highlighted on here the congregate living facilities, and they are a very vulnerable population. And we know that throughout our state that these high-risk facilities are experiencing cases. We're working with them week in and week out. I would say for the skilled nursing facilities, CMS, who is the part of the regulatory authority for skilled nursing facilities, has put very stringent standards in place for those types of facilities. That does include testing, and those facilities have since received federal resources to assist them in testing within their facilities, rapid testing, as well as of staff and of residents. It does go along with again, that's not something that we as public health can control. It's still our recommendation that people take all the precautions. But I would propose to our board that we remove that from one of the mitigation strategies here. So on this particular risk level, the items that are highlighted in yellow are those that I would recommend that we remove from this risk level. And I'd like to answer any questions that you have about it. And I guess I'd turn to James if you had other comments or thoughts.
No, no, I don't at this time.
So questions from the board for this, let's just discuss this risk level and the recommended changes.
I agree. I like it being a little more simplified. It sends a stronger message with the points that we want to focus on.
Okay, thank you. Other comments?
Mr. Chairman, this is Brent.
Yes, go ahead.
I concur with Dr. Nelson. Don't be shocked, Barbara. I concur with Dr. Nelson. I would like to see, and I do, I think it makes it very simplistic. That first bullet on the mitigation strategies, where it says issue an order for mandatory face coverings when in public, I am seeing more and more that we are, I'm seeing more and more that people are wearing face coverings when there is social distancing occurring. In other words, they're in a meeting, they're 6 to 8 feet apart, and they're still wearing their masks. Is it something that we want to say and educate the people that if you are 6 feet apart, you don't have to? I smile when I see someone going down the road in their car, windows rolled up and a face mask on, and they're the only one in the car. And that happens a lot. I don't know. That seems maybe it's too much in the weeds, but do we want to educate and say, hey, face covering or 6 feet and give them a little flexibility? Or, and I would go back to Dr. Nelson, the more we can wear face coverings, no matter what the environment, the better off we're going to be.
Exactly, especially since CDC just announced their airborne transmission data as well.
Okay, so then in that case, let's just leave it and not push out more, because I know there will be people that will, well, I'm 6 feet, I don't have to put one on, but then they go and sit next to each other to chat for a minute. So, okay, all right, just a thought.
And Commissioner Mendenhall, I would just say, originally there was very little space to do a lot of expansion on the detail. That certainly is included in the order itself, but if we're taking stuff out, we will have more space that we can be more explicit that it is for when you can't physical distance outside of your household.
And so perhaps that could be added at this point. So that probably would be good. I think we want to leave as much option for the public to do, certainly if they want to wear more in the car, there's nothing wrong with that. I mean,
I guess what I'm wondering is in the minimal risk in the green, we do define that.
No.
If we don't include that in the moderate risk, then we are saying 6 feet social distancing is out. You wear a face cover. That's the way I know people will interpret it, and they'll ask me about.
And quite honestly, we've just talked about including these key things in every single level instead of, in addition to the things in green, just replicating them in every single level, because that is our public health message.
Yes. Okay, I'm in.
So no, it's a good point. So. No, this Commissioner Young, I agree with what Brent is saying. I have run across individuals and yeah, we have this mandate, but I think a lot of them are kind of getting they forget about that 6 feet distancing that Jerry, our director, has pointed out that, okay, if you keep your distance 6 feet or greater, you don't have a mandate. And that, I think that could go a long ways in educating the public.
Yeah, and certainly, I'm sorry, James, certainly, yes, a lot of people are watching this on our website and they use the plan. And so it just makes good sense to add that as part of the language here. Go ahead, James.
Well, yeah, certainly. I think we'll replicate the language a little bit more as we have room, as Jerry said. I would just say, from a public health standpoint, I agree with you that if they can maintain their 6 feet, they do not need to. I will take individuals wearing it a little bit more overly cautious than under cautious. So for that fact, if people want to continue to wear a mask inside of a meeting that has multiple individuals, they have that right, and certainly they should exercise it if they feel more comfortable doing that. And I'll just share a little story. My son was riding his scooter waiting for the bus kind of in our driveway the other day. And I said, hey, you don't necessarily need to wear your mask right now, before he was getting on the bus. It's like, oh, it's fine. It's keeping me warm. I like it. So I think sometimes, we look and see that and think maybe something, but it could be, I've gone many of times now into my car and I'm still wearing my mask just for a little bit of habitualness. So I think overly cautious is probably more appropriately than underly cautious and getting out your tape measure and getting a 6 foot. So.
Okay, thank you.
The other thing that I did not highlight here in this explanation of what we would anticipate based on ICU rates. Originally, it was 1.5% is what we were seeing early on in our health district. It has dropped to, I think, 6.62%.
Correct.
So I would just like to eliminate that language because we are just looking at overall hospitalizations. And the point of this in yellow is that we want to be proactive. We don't want to get to that next level that does start to put the stress on our hospitals. If people can do these things in yellow, get us back to the green level where we're not seeing a hospitalization, that's our goal as public health. We don't want to advance, and it does take time for that to happen because of the incubation period of the virus. And so we are trying to be proactive in the moderate, take preventative measures rather than waiting too late.
Any other questions? So I guess my only concern with taking that out is just we want the public to understand that we are tying it to hospitalizations. And although this rate is not quite accurate, the 4% rate for hospitalizations has proven to be accurate.
Yeah.
Would that be a better number to put in this place?
Yes, the answer is yes. And I think we need to do a better job of trying to explain in writing that our plan is based on trying to anticipate what hospitalizations would come out of cases. And as we talk to people one-on-one, I can't tell you how many times I've heard, well, you should be using hospitalizations. We are. And then when you have that one-on-one dialogue and explain that, they do have a better understanding. And so we will do whatever we can to translate that into written explanation in this plan to try to get people to understand that a little bit better, because it is based on hospitalization rate.
Well, I'd kind of recommend maybe that we leave that in there and use that language. And just an observation, I'm so glad that it's not proven to be 1.5% for ICU.
Yeah.
Because if it was, we would be overrun.
Yeah.
And so we're glad for that
yeah.
number is smaller.
And when we when we put this plan together, I will just say that we anticipated the ICU admission rate going down slightly. While we don't have, a cure-all treatment, we do have increasing treatments that are keeping people out of the ICU. So we anticipated the ICU admission being able to go down, but the overall hospitalization is still there, and they have to go get maybe supplemental oxygen and some treatment for that. Yeah, I think that the suggestion of keeping some sort of hospitalization language in there, maybe tying it back more to overall hospitalizations, and then maybe some additional language, as Jerry mentioned, to try to really educate people that we are basing it off of hospitalizations. We can't, as the hospitals explained earlier, it's very hard for them to tell us on a regular basis that they're at 90% or they're at these things. So we're really having to try to look at our numbers and plan what the hospitals think would be a concern of how many COVID patients. And that number has been proven, worthwhile as we've gone on. So.
Any other questions on the moderate risk part of our plan?
And
Yeah, this is Bill Lake.
Go ahead, Bill.
I guess I'm thinking that if you've got to put some statement right here on this page that says these numbers are tied to hospitalization rates, however that gets worded. But I guess I don't see why does it hurt to not have an or that says, look, regardless of these numbers, if we see a trend where hospitalizations are going up, that we could invoke this without going necessarily to the next level where we talk about bed capacity reaching, numbers still above that. So I guess I'm not sold on deleting that or yet for the hospitals, or maybe we need to reword it somehow. But I'm open. I'm not going to follow my sword on this one.
I guess one of the reasons why we maybe recommend is we've had a difficult time getting that number on a regular basis from the hospitals themselves. So you're correct maybe in trying to reword it, but it's hard to put something in there that we can't get. And we worked to try to get that number on a regular basis to be able to do it. But it's difficult, as you've heard the hospitals report to us, that we may not be able to get that. So.
Mr. Chairman, this Brent.
Yeah, go ahead.
Thank you. James and Jerry, in your conversations with the CEOs of the hospitals, is there any way that we could say to them, because we've talked about, we would love to have more inclusion from them, that they would, be more involved in this part of helping us prevent this or slow this down. Is there any way we could get maybe something from them, any kind of a consensus from them of what kind of language would be in a plan that would help moderate the fears that, because they expressed it today, they're concerned, they still manage it, they're under control. But is there anything that you think they might come up with, or does it fall on us to say what the hospitals could handle?
Mr. Mendenhall, our hospital reps, I think, are still on the line. So if they want to respond to that.
And they may want to consult.
This is Casey. I agree. It would be nice to have a definitive direction. The biggest problem we have is I can send a report in the morning, and that's a snapshot in time of our current capabilities. And that can change rapidly based on what comes through the emergency room or what comes through transfers from other hospitals.
And that there may not be anything we can put in there, but I was just thinking of a threshold that would come from the hospitals regionally, all of you. Hey, if it hits this, and maybe that's more for the orange rather than the moderate. I don't know, Jerry. I just wondered if the hospitals wanted to have any input.
I wish I had a magic line that I could tell you to put in there, but I'm not sure how to quantify it.
Me either.
Us either.
Mr. Chairman, Wayne Butts.
Go ahead.
So while we're beating our head against the wall trying to come up with a number, wouldn't it be appropriate just to put in there that Eastern Idaho Public Health is trying to make sure there's enough beds for our ICUs in our area and let it go at that?
It seems like that's, yeah, Commissioner, I don't disagree. And I think that's the way they're kind of recommending to us, to take that out and just, but we will look for some type of wording like that.
And when we go back up here to the first page of the plan, and we talk about, in addition to metrics, that we're going to take into consideration input from our healthcare partners. Sometimes, again, we don't see that, but the hospitals can tell us we're feeling like we're going down this road, even though it maybe can't be quantified at the time. And I know we've had lots of conversations about with our partners of how we could better represent the hospital piece. And I just have not been able to come up with something that can be accurately measured.
It seems to me that when you first developed this plan, you were a little unsure what was going to go on with hospitalizations. I mean, you're putting your best, expert opinion to it and your thoughts, but now we know. I mean, we kind of know what these numbers feel like. We know how it relates in the hospital. So to me, the or isn't as necessary as it was then, because we know what these numbers feel like and look like as far as the hospital. Such wording may be more so in the higher levels that we're a little less familiar with, but in the yellow, I would support the taking it out, but I respect your opinion, Mr. Lake, and welcome it more.
Yeah, after the discussion, I'm good with taking it out, so.
Okay, well, let's go ahead and go with those recommendations for now, as outlined in the moderate risk. And if you're ready, we'll move on to the high risk part of the plan and see what is recommended there.
So I can tell you that this has been the most challenging part to try to come up with ideas. Because James and I have even talked about, do we collapse it just to a 3-level plan? Because again, there's only so much that we as public health can do. And we're giving recommendations all the time. Part of my conversation or my question to the hospitals this morning is this rate of 50 per 10,000 for the entire district. Now that we've experienced what 30 per 10,000 feels like almost, it feels like that would be a trigger point for us, that we need to take extra caution, pay extra attention. And so as I've kind of settled on, that maybe this orange is just a situational update for everyone to know what's happening in your individual counties. Because school districts are relying on us to tell them when we're seeing more increased activity in their communities, and their plans are based on some of that. So my recommendation is that we do change the 50 to 30,000. And
30 per 10.
Yeah, sorry, 30 per 10,000, and that it be done on a county by county basis. For example, right now, Madison County, there is concern there that they have a lot of activity going on. And so preparing for this meeting, I've had conversations with the mayor. I had conversations with Commissioner Mendenhall of what can we do in your county specifically? And I think going forward, it is simply going to be engaging the local leaders more than we have been at this point to figure out what strategies can we collectively put in place for the communities that are having challenges to try to get things back under control. So that goes to the mitigation strategies. And we've gone back and forth on the limiting of gatherings to no more than 50 people. That was our original recommendation. When you look at what was in place during the state's rebound process, as well as recommendations that have come from the White House that states that are in red category as far as their categorization. In the red level with high daily case rates, high test positivity rates, they're saying limit it to 10. But it just goes back to, we want people to physically distance, and that's included in the yellow. And so I would certainly like to have dialogue among this board of, is there a valid reason we would put a number on that?
Mr. Chairman, I probably being from Madison County and where we were in the spotlight, I liked it better when we were the donut hole and in the spotlight because we didn't have any. But there's two things, Jerry, that I need to ask, and I can't remember. Refresh me how we came up with 30,000 and why not, or excuse me, why we came up with 30 and not 40. But in connection with that, before you respond to that, you or James, looking at the hospitalization rates, we have that paragraph underneath that in small print in the orange. I'm not comfortable. I'm not sure that how comfortable I am that we just use active cases, because that chart that showed Madison hospitalization rates at 1.9%, would that justify moving into the orange if our hospitalization rates are not through the roof as well?
And Commissioner Mendenhall, it goes back to what we're recommending as the mitigation measures. If you look at what's highlighted in yellow, we've not talked about all of that yet. My recommendation is we delete everything that's highlighted in yellow, and it goes back to, it's the same public health message. Stay home when you're sick. Limit your interaction with others outside of your household. When you can't do that, wear a face covering. And again, it's more of just a situational awareness for Madison County that things are increasing in your county. And if you didn't take it serious before, maybe you want to think about doing things a little bit differently now. One of the things in here specifically is that we had included was the hospital piece and suspending scheduled surgeries. We know that there's still ongoing effects of people's health that from when things were closed down before. And again, it's the hospitals, but it's also the businesses that we want them all to be doing what they need to do to be able to function and not close down. And so we put that onus back on the businesses. The public health mitigation measures that we're promoting are going to allow people to continue to function in business, in school, in the hospitals as much as possible, and put it on them to reserve the resources that they need to be able to continue functioning. Because our public health message does not change.
Other
Mr.
comments
Chair?
from board? Go ahead, Bill.
You know, as I'm looking and thinking of this, is the reason you are moving towards the orange level is because the mitigation strategies from the yellow level and the green level aren't working. And the only thing I can think of is why they're not working is because people are not doing them. So at some point, you have to go out there and find out who isn't doing it. And maybe the the strategy at this level is to put together I'll call it a team that goes out, spends a few days in the community, goes around. They're not out there to issue tickets or warnings or any of that stuff, but they just observe. And then we collect that information based on the observations that we see and come back and say, these are areas where you could do more education, or you could go out there and maybe actually help people, a business, understand that if they would just simply put out a table in the front of their door with a box of masks on it, maybe people would wear them. All kinds of little things like that. Short of my first thought on this, and I'll throw it out there, was we actually start doing the enforcement and we get the sheriff to do it. Because my personal opinion is that any of the sheriffs right now that say they're not going to enforce this, they're not upholding their duties and their obligations. Okay. Now, short of that, and I don't want to go there, but until you get out there and actually tell somebody, let's say you walk into a classroom at a school and it's obvious that it's not working. Well, somebody has to talk to that teacher and say, look, we're under a mandatory mask order, whether you like it or not. So you either the teacher has to buy into that, or maybe that teacher needs to be asked to do something else so that somebody else can do it. I know that's very strong language and discussion, but obviously you got to this point because people weren't doing the right thing. I'll just throw that out there and welcome any other comment.
And I would just say, Bill, that while we can give recommendations, people have to take personal responsibility for their actions. And we as public health can't control that. I would include in this section, just like I have done this week, having conversations with the local leaders of that jurisdiction to collectively strategize what can be done in that individual county. And I just want to give a shout out to Mayor Merrill for the efforts that he's personally taking to try to improve things in Madison, in his city, in Rexburg. I appreciate what BYU Idaho has been doing that's within their control to improve things in their community. And I know we could debate this back and forth all day, but public health cannot force people to make decisions we want them to make.
Well, Jerry, I have to respond to that because I know in our food establishment licensing, we just heard from Kelly that she had to shut down a business for a day or two. So it's not something that we want to do, and I'm not advocating we do it, but what I'm trying to advocate for is that we go out and help people try to help themselves and understand why it's important to do it. I'm not saying that we go out and issue and shut anybody down. We just make an observation and point it out to them. And if the community leaders are willing to do that, and it's great the mayor did, then we wouldn't have to. But if you're talking about a mitigation strategy, you got to this level, but there's nothing, we're not going to do anything differently to further mitigate it, then we don't really need that column.
I think that some wording in here to encourage those local elected officials, that would include school boards and mayors and commissioners, it would include everybody, is a mitigation measure though. I mean, that's how I would respond to that. I think that is the place where they go out and find out what the breakdown is in their community. I think public health is doing all that can be done, and there needs to be responsibility with everybody. And I know we've seen it, and I agree with what our director said about Mayor Merrill. I really appreciate how he's just stepped right in to do that. Excuse me again. And I think that that's a good example of how it can be done with local community leaders. They're the elected officials along with all of you that represent your counties, but it helps spread the responsibility. And again, we've seen a great example of that there in Rexburg, and we will see benefits from that, I have no doubt. There needs to be some responsibility with other leaders and individuals, I think, and that is what this does by doing what our director's recommending here. It just highlights it. It puts it into, okay, you're in the high level now. Time to look for the measures that you're talking about, Mr. Lake. Sure.
I thank you for that, and I agree. It doesn't have to be a public health person that's out there, but obviously people aren't following the rules. Somebody needs to go out there and engage with them. And I'm good with the community leaders doing that. Thank you.
Mr. Chairman, Wayne Butts.
Go ahead, Commissioner Butts.
Isn't it true that the mayors have more power and authority than this health board?
No, I would say equal. The mayors do have the authority to do citywide ordinances. I wouldn't say it's more, but certainly they are more directly connected to the people within their cities and may have more influence that way. I would agree with you on that.
Mr. Chairman, wouldn't they have the opportunity to enforce versus where we're not an enforcement agency?
Yes, cities do have the ability to enforce their ordinances. That is correct. Yeah. Yeah, no, you're right on that. An individual city can do an ordinance and they have enforcement ability for that ordinance. Yeah, good point.
And Mr. Chair, Bill Lake, I will share with you that I just learned that the cities here in Teton County are taking a serious look at the enforcement thing.
And yeah, that's a good point by Commissioner Minor. They do have that ability. Other thoughts or discussion on this?
Mr. Chairman, Wayne Butts again.
Go ahead.
I guess that's the point that I was trying to make as far as the same thing that Commissioner Minor did, that, it's okay for us to make recommendations, but if the cities have the power to enforce, and if they don't like what they see in their community, then they could come up with that ordinance instead of us mandating.
Yeah, I better understand your point now. And yes, I agree. They do have that.
This commission should not only be for the city though, not the whole counties.
That is correct. It's just the cities. Other thoughts about all that's being recommended to be deleted? It looks like we have put in the language to connect with local community leaders to develop local education and mitigation efforts.
And Mr. Chairman, I would this one that's not highlighted already about the vulnerable population, I just go back to what we said previously, is that encourage them to take extra precautions. And with precautions being taken, ideally, no one will have to isolate themselves.
In some ways, it does play into the focused protection. Is that what it's called, that term? And if my understanding is correct, it would still include all the mitigations of the yellow level. So they would all carry forward. And it would just be those basic, like Dr. Nelson said, emphasize those core important principles that really will help slow. And again, I think it works into that declaration that was put out. I think it works hand in hand with it. It's kind of meeting in the middle in a way to try to do as much as possible to keep everything open and going with, without the harm that comes from closing anything. Other comments?
So, Mr. Chairman, help me understand, if we take out all, and Jerry, please, if we take out all of the yellow, why do we need an orange category? I mean, it's not escalating anything, and I'm still I'm looking at this and I'm seeing, okay, public health work, that does that. But prior to taking out this yellow, the way it was moving it up, limiting groups to 50, hospitals suspending. And if we take all of that out, why do we have an orange?
And again, that's what I mentioned earlier. It would be just more of situational awareness that there is more disease circulating in the community, that people can be informed of the current level of activity in their community.
Okay.
In essence, a visual,
Yeah.
A stoplight, if you will, or just something visual to say, warning, this is getting very serious.
Okay. And my last comment, I'll go back to that paragraph below the metrics monitored. Idaho's current hospitalization rate is 4% of all positive cases. I would recommend we either edit that or we take the hospitalization rate off of public health, because I know already somebody's going to see 1.9% for Madison County hospitalization rate, and they're going to go, what'd you move us to orange for? We're way below the state average. And why just active cases? Isn't it hospitalization? So probably I gotta find a middle of the road there somewhere.
Mr. Chairman, Wayne Butts.
Go ahead.
Why wouldn't we do the same thing we did on the one before? Just basically take it out and say that we're trying to make sure that there's enough beds for our ICUs in the area.
Yeah. And Commissioner Butts, Wayne, I think Jerry's typing in Eastern Idaho's current hospitalization rate. What is Eastern Idaho's?
0.2.
Say that again. How many? I lost that.
4.2.
Okay, 4.2 in Eastern Idaho. So we're still well below it. And I'm trying to know that in a community that is on the hotspot, that I can defend the plan and actions taken. Not that we're going to move Madison to orange. We haven't considered that yet. But if we did, that's going to be just glaring in my face. I can hear it already.
And I think that's a good point, Commissioner Mendenhall. And I think that's why we didn't feel the extreme urgency last week to do something before we were better prepared, is that we did understand that a lot of those cases were young people in the hospitalization. So I didn't know the number at that time, but I knew it was going to be small compared to
yeah. I didn't either. I wasn't aware. It surprised me.
Yeah, and so I think that was the reason we didn't feel that urgency last week, although we saw the numbers climbing dramatically.
I would just add on, because it was referenced earlier, Madison is the New York Times in the nation, the hot spot, in the top hotspot in the nation. Again, we have not focused our plan on the daily case rates, but increasing cases is also concerning.
Oh, yes.
And so I don't know how, again, as we take out the restrictions, it is just a heightened awareness that there is increased activity in Madison County. We certainly could put in the daily case rate is at those levels as recommended by John Hopkins or others. And if we were to do that today in our plan, Madison County would be at the red level.
Yeah, no, I understand that. The New York Times also has Madison County at 59,000 population. So, I take information from that.
That's the metro area that includes surrounding communities.
I was thinking they showed Rex. It doesn't matter. That's in the weeds. What I'm after is this plan. I am not one that could support that we're going to move a county based on active rates only if we keep touting that we are working with the hospitals and what is the hospitalization rate. That's my bottom line.
Mr. Chair, also on the fact that Madison's rise, so their cases have risen so much, but it's also because they've testing so much also. They've raised over 500 tests in the last couple of weeks, more than they were doing originally. So obviously the numbers are gonna go up.
But James, and I'll let him speak to it, but he did explain that there's more testing because there's more symptoms out there. You know, there is more illness, which drives the testing. Correct me if is that correct, James?
That's correct. As well as we know that there's other individuals that don't get tested that play into the hospitalization rates that we aren't aware of. So if testing goes down, hospitalizations may stay up if that's the case. That's one reason why we've left the hospitals in. But I will just go back, and we've heard the hospitals talk. It's very difficult for them to give us a metric that will show that we need to pay more attention. And so we're certainly then trying to come up with a number, and this number has been proven out that this will lead to hospitalizations. Maybe not specifically for your county, although that rate changes on a regular basis. If those cases start increasing in populations that will have hospitalizations or potential higher percentage of hospitalizations, it will go up. I would just say that I think that we recognize that, and we've talked that maybe reducing the number of phases. I think that it's important not to go straight from yellow to red. I don't think that's not giving people the opportunity to make informed decisions is why we have that fourth phase. We're requesting that maybe we look at, there's not any increased mitigation strategies other than slightly some more education with local leaders to help us get that rate. But really the simple measures all the way through are what's actually going to get us back into a position where we're not overwhelming the hospitals.
Mr. Chairman, Wayne Butts.
Go ahead.
I'm sorry. I'm at my shop and had to visit with a customer real fast, but I need to back up to what we were talking about earlier of the health board making suggestions to the cities that here is where we are at today. And hopefully they would make some kind of an ordinance that could be enforced, but still in the same token, who's going to hold the cities accountable?
Well, yeah, they hold themselves accountable. Frankly, it would be my response.
I mean, right now we've got the governor pointing his finger at us, telling us that we're not doing our job, and he's the one that put us in this position in the first place.
And I just go back to, we want everyone to take personal accountability to protect themselves and their neighbors.
And I'll just add, this is James, I'll just add on if I may. If they weren't doing it in yellow, we'd hope that an increased awareness of even more cases in orange, they would take that opportunity to do that. Whether that's a local elected official or an individual in a home or a vulnerable population, whoever that individual is.
And I apologize for my comment. It's just really frustrating.
No, we understand.
This Commissioner Young, you know, I certainly understand what everybody's saying on this, and especially Commissioner Mendenhall being in this situation because, you know, they have a lower hospital admission rate, but and that's wonderful. But the kids today, starting in high school, they're so mobile today, and they're going everywhere. Whether it be Idle Falls, Pocatello, or California, I've been surprised at how mobile they are, starting in high school, and so it does spread to other counties. And I guess I'm along with staying with the rate the way it is for each county. Maybe the only thing I do feel like that some of our spread is happening in these private gatherings and get-togethers and groups. I don't know. Maybe consider. I'm for the plan, the omitting some of the things, but I'm wondering if maybe we should leave one or two, the highlighted yellow ones in there, like the limit the gathering of 50 people. Just a thought, but I'm fine either way.
And Commissioner Young, thank you for that, because the point you make is very valid, that if people, and we'll talk about Madison County, if people were just to stay in Madison County, it would only impact your county, but that is truly not the case. They are very mobile, and that's true for every county in our health district, traveling back and forth and having interaction, that it does introduce disease to other populations outside of your individual county.
Commissioner Mendenhall, I guess I would just need to ask you, I understand your concerns, and certainly, as you said, the hospitalizations are low there. And so you are in somewhat of a unique situation, perhaps, but does it settle your mind any that there are not additional mitigation strategies that go to moving to a high? Is it more just a symbol that you think would be offensive, or because go ahead.
No, you're right. You're on the mark. And Director Rakow had made, and even James had made the comment, we don't want to go from yellow to red. I like it that it is a warning. It is, and the consequence, if we continue to climb, I don't know how we get to the red. I can't find out how we do that. ICU consistently at or above 100%. And again, if that's the case, our hospitalization, we're not going to get there. But if it continues that way, I do like it as if it's time to move and say, okay, Madison, you move to an orange, but we're going to have to make sure that the public understands that number of 50. I can't tell you how many phone calls. Hey, I'm going to have a wedding. I'm going to have the gathering of the Sons of the Pioneers, and we want to know if we can meet because there's more than 50 people. And I tell them, yeah, I forget the number, 2.87 square feet, 6 feet apart, whatever. So yes, that does. That helps. It does. That as a warning, as, hey, Madison, pay attention. You just jumped up a level. I do worry of a little bit of what Bill was saying. What's the consequences? We move to yellow. Okay, we have more cases. Well, as long as mayor keeps putting all those big numbers up on that billboard, everybody in town knows that. But yes, I do like the restrictions being a little more tempered.
Other thoughts or concerns?
Mr. Chair, this is Commissioner Minor. First off, I know we went all the way back to July 21st when we implemented this program, and just kudos to James and Jerry for their vision of putting this together and coming up with some numbers that they had no clue about prior to, as far as just what do we put it at. And they've been pretty spot on with what they've done. And that really has to be recommended, or, brought out how well they've done there. All this is clear as mud for all of us. We're all fighting through this, but I really appreciate what they're talking about now, is simplifying this thing and putting it on the people to do the right thing. And if it gets, I think, to that high level, we have to call on our community leaders to push harder within the public. But where we stand right now as far as educating, because that's what we are, we just are, we advise and we give the best recommendations we can, and we've been doing that, and we've done a great job with it, and we just need to continue doing that. We haven't overrun the hospitals yet. God forbid that we do. I hope it doesn't get to that. I hope that where we're at right now is just kind of the top of the plateau, and we start to taper it back down now as things go. But I think we just need to move forward with what Jerry has in place here and do the best we can.
I concur. Thank you, Commissioner Minor. Yeah.
Commissioner Butts, I concur.
I think that was well said, Commissioner Minor. Other thoughts?
I just want to acknowledge that there, are people that already think we've been doing too much, and there's others that think we have not been doing enough. And we, as public health, as was said earlier, there's only so much we can do, and people need to take personal accountability. I think what we can do is, because we know that face coverings help slow the spread, that is within public health's wheelhouse to say, no, this is what we're doing for public health, put the order in place. No, we can enforce it, but again, we can work with our local leaders in each of our counties to do a better job of coming alongside with us to educate their public for the reasons why we're putting these measures in place. We're never going to be able to force everyone to do what we're asking. But the majority of people that can do it and understand until we get to the other side of this pandemic, that's our goal.
Are there any other questions on the yellow as you contemplate it? It is a change. It's a fairly significant change. I go back to how I was feeling last week. We can't continue to do the same thing over and over. We've got to look for the best way to get the best use of what we can do to get the most people that comply and agree with and will help us in what we believe will be the best outcome. And this does make partners of those local community leaders. It broadens those who are out helping and working with us. Okay, hearing no other input, we'll move to the place that none of us want to get. And I believe, I hope, don't take away my hope that we will never get here.
I'm not able to get this on the screen, but it says hospital occupancy. Including ICU consistently or above 100%, and surge capacity cannot be maintained. Just for clarification, this is our regional hospital occupancy, not one individual hospital. And the other component is, or crisis standards of care are implemented. And I don't, and that's, again, the formatting of this document, I apologize, it's over here, but I don't know what change we could make to this level. I mean, it really is when we get to that point that the hospitals have no capacity.
And if I may, this is James. I would just say that the other two levels, yellow and orange, that being, or the moderate and high, we're trying to be somewhat proactive in the approach of educating people and having them do something. At the red level, we're not willing to make a guess of what that rate would be or any of those things. It is really if the hospitals are overwhelmed, or they essentially the same thing, but implement crisis standards of care, which one hospital cannot implement crisis standards of care. The surrounding hospitals in that region have to do it all together. going back to that education that we heard on that. So really, if you're asking yourself, well, why don't we have a rate in red when it gets to that point? It is really, we're not going to venture a guess what that rate would be.
Thoughts, comments on this?
James, this is Commissioner Young. So the way I understand it, the critical stage, the red stage, it is possible that that could be implemented even though our rates are lower, correct? If our rate, say, is around 25 and for some reason we had this, I don't know, outbreak where a lot of vulnerable people were affected and it started over in the hospitals, then the red zone is essentially the trump card where it comes in and takes over, and we have to do different measures. Is that correct?
Yes, that's correct. I would just echo Chairman Reed's point that I maintain hope that we don't get to that point.
Yes, absolutely.
I do not want to see a stay-at-home order issued again anywhere in this state. There was, looking back now, knowing what we know and looking back, I don't criticize the leaders that made those decisions, but we've learned a lot since then. And I would never want to see that happen. And so I hope that all the mitigation strategies that are being put in place, including those that are happening now in Rexburg by the mayor and others up there and in all of our communities. And I think we would ask all of our community leaders to do what they can to help our message. Sometimes we feel a little bit alone out there in what we're trying to do in this work. And we would ask all our community leaders and citizens, everybody, to kind of help us with this message a little bit. I don't want to ever see us get to a stay-at-home order again in this country. That's my thoughts.
Mr. Chairman, Wayne Butts.
Go ahead.
Hey, could we go back to the orange level real fast? Because I thought we had comments about taking out the discussion or part about hospital numbers or whatever. Yeah, I thought we took out the part, or we had discussed taking out the part of Idaho's current hospital rate. Or did we not make the decision on that?
You're talking in the red level or in the orange?
No,
or in the orange?
In the orange.
We had changed it in the yellow, I thought, and it would only be appropriate if we changed it there also, that we're only trying to make sure that there's enough beds for our ICUs in our areas.
James?
I think that statement is going to be incorporated throughout our entire plan. So I don't necessarily see it being right here, but we're going to focus more on the hospitalization piece earlier in the plan for better explanation.
I think it's just as Commissioner Mendenhall said, though, if we leave a number out there, whatever the number is, and whatever side people are on, they're going to use it against us or for us, or if we just got rid of the numbers, it would be better.
This is James. I would just say that the number for our region at 4.2% is how we get to the rate, though, of what would be concerning. If we don't have a number, now we're just saying that this rate is not based off hospitalizations necessarily. So I do think that there's a balance. I don't think we've had that language exactly finalized. I think Director Rakow has a very good understanding of what the intent of the board is, of trying to make that more prominent and make it more understandable for individuals to understand that the plan is based off hospitalizations. But I do think that we're going to have that percentage somewhat play into that message so that people can understand how we came up with it.
Okay, well, I appreciate you going backwards. Thank you.
I understand the point if we are taking the action based on an individual county, but using the rate based on the region.
Yeah.
That is problematic.
It is certainly. I think what it does though is we could look at an individual rate for each county. And I think we talked about this in July as we were developing it. There is some benefit to being a little bit consistent across our region because we do see some inconsistencies with smaller numbers, right? So Teton may be at 1.9% right now, and then they may get a spike in a long-term care facility that their rate is now 10% like Clark County is. So do we want to base Clark County's off of 10% and Madison's off 1.9 and Bonneville's off 5.1? We would all be using a different rate. If that's the desire of the board, I think we can certainly, entertain that and do it. But I think then it leads to some inconsistencies with people's knowledge base across the district. For that reason, I think, and it would be my recommendation that we use the consistent number that we see across the region.
So just for the sake, Mr. Chairman, just for the sake of public understanding and maybe not contributing to their confusion, perhaps we need to move that paragraph down underneath item number 2. Item 2 deals with services and hospitalizations. Item number 1 deals with active cases.
And I guess that the active cases, we're only dealing with the active cases because of the hospitalization.
Okay. Weeds, semantics. Okay,
yeah.
I'm fine.
And I guess, I recognize all of those concerns and I get them. I'm not trying to be dismissive. I hope that comes through. I just think that especially we're trying to base it a little bit proactive in yellow and orange. We're doing that off of rates that we would expect would be concerning for the amount of hospitalizations we're seeing. And orange does not necessarily increase someone's ability to continue their lives. It's more awareness and education again.
Yeah, I understand your thoughts, Commissioner Mendenhall, and I guess I would go back to the comment of people are moving in and out of all counties, right? So they're even though the rate is maybe high up there right now, but the hospitalizations are low, they may be going into other counties where our hospitalizations are higher. It is a difficult one.
No, it's good. You are right. If we blocked every 2F, 1T, 1J Wyoming plate at our borders, we'd be a ghost town. Just saying.
Sounds good to me.
Not me.
Mr. Chairman.
Yeah, go ahead, Commissioner Miller.
Sitting here listening to this and I understand where Brent's coming from totally. But I think when earlier on in the discussions today, we talked about the high rate in Madison County was due to the younger people. But as those numbers go on, the older people are going to be more vulnerable. And so that has to me, that has a great effect on how we address that. And I like the idea on that number 2 is that it may reduce the services to the hospitals. So I think we need to, look at it a more broader spectrum than just the college is the cause of Madison County's issues.
That's a good point, Commissioner Miller, it does. I mean, that's like we talked about back when we were talking about the declaration is a higher caseload amongst any population does increase the chance of it getting to those that we are trying to focus our protection on. Thanks for all the good comments. I think it's been a good discussion. Is there other thoughts?
Mr. Chairman, I would just ask, because there's been conversation about the limiting the gatherings to no more than 50. What is the pleasure of the board on that particular item?
So your thoughts on the limiting to 50? I understand the thinking there that if we're doing the social distancing, then, you know, that becomes a little more mute. If people were always doing that, then it wouldn't matter if they had enough room to spread people out. But what's your thoughts on the board of leaving that in? Or I have some concern that it may hurt some businesses or places that have the room to have more, but cannot because of that. Thoughts from board members?
Commissioner Minor, I just think it's impossible to enforce.
Yep, I would take it out. I agree with Commissioner Minor.
Okay, other thoughts?
So this Commissioner Young, I could see where it would be nice to have it in there if people followed it, you know, in social gatherings. I don't know about businesses, but I'm fine with taking it out myself.
James?
So this is, like Jerry mentioned earlier, this is an item that we've talked about a great deal, and what that number might be, you know, whether it would be 50 or, as some national, you know, publications say, maybe 10. I think it is, if the individuals are doing those simple measures of 28 square feet per person, that will add to that 6 foot radius, or allow 6 foot radius, and they're following those other measures, they can safely congregate. I do share, and we, you know, Commissioner Young's not wrong that we do see groups in that 10 to 50 range really is where a lot of transmission can occur. But I think if that's due to their fact that they're not following those other strategies appropriately either, so.
Okay, Mr. Lake, did I cut you off? Were you gonna make a comment?
Yeah, my only comment is I agree with taking it out, but maybe it's not here, but put in somewhere if you're going to have a gathering, that encourage them to work with the public health office on mitigation strategies or something.
Okay. We could put that in the first part, what to know about, or if you wanted to put some of that language in there, perhaps, Jerry?
We could include that in yellow, actually, because we have guidelines for gatherings that is good for everyone to know at all the time.
Okay. So it could go in the yellow, and then that would carry through.
It could go in the yellow under that second bullet, restrictions on events and social gatherings. We could just include consult with the Eastern Idaho Public Health Office for, I forget what the word was that they were used for the strategies to set that up. We could put it there.
Okay.
In the yellow.
All right, we'll do that. Is there any other discussion? If not, we would need a motion to.
Mr. Chair,
Just a minute. Go ahead, Director.
What I've shown on the screen now, I know we've had discussion about this at previous meetings, and I don't want to include this dialogue without addressing that one way or the other.
Yeah.
And I know it's Dr. Nelson that brought this forward at our last meeting.
Yeah, it has been discussed that perhaps to help with the yo-yoing and to help with the whole situation, that we need to increase the days to 14 that a county would be in before they would be moved back down a level from 7. Dr. Nelson, I assume that you feel that would be the best.
Yes. We're working kind of on 14-day cycles and we need to at least have one.
Yeah.
I'd prefer two, but I'll take what we can get.
Does anybody have any concerns with that?
I don't have a concern with that, but I do have a concern. Since we're going to move that up, do we also want to move the criteria for moving into the next level from 3 days and move it up a little bit just to see if there's some differences going on there?
It would help. Would that help in the?
So I will say that as our testing has been increasing, the capacity to test symptomatic individuals and get quicker results, we commonly see counties stay for at least 3 to 7 days easy enough on the metric to get them in. I don't think that's going to change a county going into the up next threshold. Certainly increasing from 7 to 14 days to reduce down will probably help with some yo-yoing, but as I showed you earlier, and I hope that is taken in the right context, that it's not going to create all of that yo-yoing effect, especially in those smaller counties. It will help some, but some of those smaller populated counties certainly will still have a potential for a quote unquote a yo-yo effect.
I'd like to keep it at 3.
The going in.
Yeah.
I don't think going from like 3 to 7, and I'm just using a number, if you're thinking of increasing that, would change many of the counties. I could go back and look, but just thinking through it anecdotally and remembering what I can of the rates, I don't think it would actually change any county or what we've done for any county previously. Maybe early on in July, yes, but as of recently, I don't think it would have changed anything.
Other thoughts on that specifically, and moving bottom number as well, Bill?
I would actually like to see the first item where it says after a minimum of 14 days, I'd like to see that 14 days doubled, because going in and out of an order in 2 or 3 weeks, it's a real problem, and most of you guys haven't had to deal with it. But here in Teton County, it's and we see those numbers changing that quickly. So I would like to propose 28 days. It doesn't hurt to be in the order for 28 days.
It's going to be more anyways, because you have the minimum, plus if they don't reach it for the 14 consecutive days being that way, it's going to move out to 21 days probably, or something like that. So
yeah, I understand, but we've been through this, I forget how many, 3 times in Teton County. We can't continue this. It's too confusing to the people, to the schools, everybody out there. And particularly, I would also advocate for, if we're going to go into lowering a risk level, I think maybe it ought to be up to the individual county representative to make that decision along with the doctor on our board. Maybe
Mr. Chairman, Wayne Butts.
Go ahead.
Based on what Bill wants to do, you're going to have to go throw it in on a population deal then, because Custer County, it's not going to fly here.
Other thoughts, other counties?
Mr. Chairman, is there any way we could put language in there, another bullet or after that second bullet that does say local county commissions, where it's on a county basis, local county commissions can request the health order stay in place for a longer period of time. I really think we need the county commissioners to have a little bit of skin in the game and not be pushing it off onto Eastern Idaho Public Health. These folks are out there trying to do everything they can, and I think they need a little support from the local county commissions. So I'd leave it there. And then I would say county commissioners have the option to request Eastern Idaho Public Health leave this in place. And then they have to give, the county commissions have to give the reasons, the dates, and we'll leave it at that. I don't know. We're going to create more confusion by extending out to 32 days or 40 days or 18 or 24. Let's set it in there and then put it back on the county commission and let those counties do it.
And we're in
Custer
this
County
bill,
would support that. Custer
yeah,
County
this is
would
Bill Lake. That
support
would work for us too.
Yeah, I think that's a good point. And again, as we've said, cities can enact their own, as Victor and Driggs have. I mean, they can do their own as well. I would
Yeah,
say,
and if it's already written and the health order is in place, the language is there for them and they can request, and I don't know, Jerry, the legality of it, that you can acknowledge the county commission has requested, and it will remain in place, and they'd have to give a specific time frame. But that doesn't need to be in the order or in the plan.
Mr. Chairman,
go ahead.
I really like that idea because we've had this conversation twice concerning Teton County wanting to leave themselves into that higher bracket, and this relieves the board from that and gives them more input is what we're doing too. I like that idea.
And it helps Wayne. It helps Commissioner Butts and even Commissioner Minor, smaller populations, to perhaps be able to address that as well.
Certainly does.
No, that makes good sense. Is there other comments? So you can see that they've added it in, that wording.
I just don't know exactly the perfect wording.
You might just put, Jerry, respective county commissioners have the option to request the health order stay in place until a date specified.
And this would be dependent upon that they fall into a lower level, correct?
Yes. Yeah. And it's under the bolded heading of reversal to lower risk level can occur.
Can I clarify? Is that, because right now we have it written as 14-day period as well as that new language? Is it the board's desire to have 14 or to leave it at 7 and that?
I like the 14.
Yeah, move it to the 14 plus the option with the commissioners. But
yeah,
I think now's a good time if we're going to increase that from 7 to 14 days. Now's a good time to do that.
But we don't
Some
need
of
to
us are
change
not-
the minimum 14 days of the first time.
Some of us are not going to see that 14 days, perhaps in my next 4-year term, I hope. I don't know.
No, this is gonna turn
Yes,
around.
we are. We're going to get this. We got this.
Thank you. Any other comments before we take action on this plan? That we have made significant changes to. I think they're improvements based on what we have learned. And hopefully will help.
So, Mr. Chair, Bill Lake.
Go ahead.
I think we've done a great job here, particularly with help with Jerry and James, and all of us being able to kind of throw our thoughts out there and come up with this. Before we vote or anything, can we talk a little bit about the next steps? Is because once we make the changes today, it's going to take a while to get this thing published and back out there. And I guess I was wondering, is there any way, Jerry, could we summarize and get a press release out that summarizes the changes so that people aren't waiting around several days before they can actually see it?
Of course we can. In fact, we've had already media being in touch with us wanting to talk later this afternoon, so we can get that message out to the public.
Okay, thank you.
One thing may I just ask Mr. Chairman, and for the orange level now, since there's no action being taken, could I request that we automatically move a county in and out of the orange based on them hitting that metric for the 3 days period as outlined, rather than having to call a board meeting and take any particular action? We're not issuing orders. We're not, again, taking any restrictions.
Would that only be for the orange then, not for the yellow?
Yes.
Yeah. Anybody have any concerns with that? Allowing them the ability to just go ahead and move a county into orange based on the metric, since there's no further restrictions being added. It is just simply a visual to a notifier, if you will.
And a call on the locals to really lock down, local officials.
Yeah. Any concern? Go ahead, Commissioner Shenton.
Yeah, I was just wondering about that earlier, moving in and out of these risk levels. If we set it up the way we want it, why do we have to do the motions? Why can't we just have the health district do that?
Commissioner Shenton, it was my understanding from our legal counsel to actually issue an order of restriction, the board would have to make that specific motion. I will consult with him again, and if we can get confirmation of that, or if it's changed, can bring that back next month or our next meeting, and we can follow up on that dialogue.
If my memory serves us right, I think the reason it was that way is because of that word mandate.
Yeah, it's a formal order of restriction, the legal document issued by the board.
It could perhaps be rescinded without action. No, it would take action to do that as well. Okay. We'll do a little more research on that, Commissioner. For now, we would have it only apply to the orange level because there would be no further order issued. It would be the same.
Okay, thanks.
Is there other discussion? If not, I would entertain a motion to approve the revisions to the plan. Just a second, there's one. Go ahead, James.
Thank you. As I just read it now, we actually don't have to have probably both of those bullet points, because we don't need a minimum of 14 days because we have to be below the metric for 14 days. We would not need that first bullet point on that.
That would relieve a lot of confusion, because I was looking at 28 days. Could. Yeah.
That's a good pickup. Anything else? If not, I would entertain a motion.
I move we accept the changes on the regional response plan.
Thank you, Dr. Nelson. Is there a second?
I second. Commissioner Minor.
Okay, we have a motion and a second. And the motion will be to make all the changes that our director has highlighted. They've all been discussed today. Is there any discussion or questions on the motion? Hearing none, all in favor, say aye.
Aye.
Aye. Is there anyone opposed? Did anybody abstain? Okay, thank you. We will make those changes. So we'll go ahead and move to the next item on our agenda, which is a discussion and vote, which actually there's no need to at this point. So based on what we've done, that will move Madison County to the high risk according to our plan. but there will be no further mitigation restrictions yet. No further actions needed from the board. Any questions?
Just one, in response to that, when there's a movement, doesn't matter if it's Madison County or who, but when we move to a higher level, I can't remember, Jerry, do you send a written notification? Somehow now that we have modified this orange, it would be nice to notify the mayors, both mayors and the county commission. Actually, yeah. Anyway, the two mayors and the county commission, hey, you have moved to the orange level. This serves as a caution to you, or whatever, some kind of great diplomatic language.
Absolutely.
Okay.
And I would just like to say that follows on with the board or the district encouraging the local officials to do more.
Yeah, it does. It would be all inclusive with that. Any other comments? I think it's been a productive meeting. I really appreciate the broad discussion that we've had, and appreciate what everyone is doing in all of their communities, not only all board member, all public health, all the work they're doing, but also what everybody is doing, the mayors, all the other elected officials, the school boards, all the individuals. We receive so many comments from people that are trying so hard, and I just appreciate what everybody is doing. This will turn around with all of the work and added increase of effort that is being put forth. I'm confident that we will get control of this and get off the New York Times list. Any other comments?
Mr. Chairman, Lee.
Yeah, go ahead, Lee.
Okay, I just want to just echo what was said at the beginning of the meeting today about the staff at Eastern Idaho Health and the tremendous work that Jerry and her staff does. And for you, Brian, as you lead this discussion each time, we couldn't be in better hands with this health district than with the staff and your leadership too. And just want to thank everyone. And I know people in our county appreciates what's going on. And we see that from the emails that we receive. There's so many people that are grateful for the health district and what they do. And I just want to share that with you.
Thank you. Appreciate that. I've said before that I just have full confidence in every one of you on this board. I know as we come together that, and with the recommendations that we're getting, that we're making the very best decisions that we can, and we're making them for the right reasons. Probably won't have everybody agree, but I'm confident that we're trying to do the best we can and for the right reasons. Any other business needs to be taken care of, Jerry? All right. Well, again, thanks to all of you. We will meet next Thursday, or excuse me. Is there a need to, what would you like us to do?
Mr. Chairman, I don't anticipate having any business for next week. So if the board is open to that, we could plan for 2 weeks.
Okay. So at this time, we will plan for 2 weeks from today, back to 7 or 7:30. What do people like?
7.
7.
Yeah, 7's good.
I would agree.
7's good.
Yep, I would agree. So we'll plan for 2 weeks at 7. If something happens and we need to take action sooner, just let us know, Jerry, and we'll be responsive. So again, thank you, everyone. And we'll go ahead and close the meeting.